So the first lecture will be by Dr. Katrak, and he's going to talk on clinical approach to peripheral neuropathies, a lecture that I think you all are looking forward to. So, Dr. Katrak, sir.
Fine. Thank you and good morning to everybody. Welcome to this edition of the Continuum. I'm going to take the first chapter of this Continuum, which is written by Zachary London. However, I've gone through this whole chapter and I'm going to follow the trends of the chapter, but I'm going to put it in my own way. Fine. Why is it not changing? Somehow my slides are not changing.
So you unshare your screen and again share. Maybe that.
I'm just trying to end the thing and again go back and see whether it works.
Correct.
Yeah.
Yeah. Fine,
Okay.
Fine, sir. Fine, sir.
Yeah. Now, peripheral neuropathies can be classified according to the pathology that you're dealing with. For examples, you can call them neuronopathies. You have a sensory neuronopathy, which are essentially involvement of the dorsal root ganglia, also called as ganglionopathy. Or you can have the motor neuron affected, where you have anterior horn cell disorders. Or in the peripheral nerve, you can classify them according to Wallerian degeneration, segmental demyelination, or even axonal degeneration. Now, this is just diagrammatic representation. On the left-hand side is the normal motor neuron going up to the muscle. The second from the left is Wallerian degeneration. If you cut the nerve at that point where the arrow shows, the part of the nerve distal, the axon as well as the myelin degenerates. If you have a demyelination, you have internodal demyelination, which is called as segmental demyelination. And the last one is, again, instead of cutting the nerve, you involve the axon in a metabolic or toxic process, and the result is more or less the same. If you note diagrammatically that in Wallerian degeneration and in axonal degeneration, the muscle atrophies. Whereas in a segmental demyelination, this is not very prominent. You can also classify peripheral nerves according to the etiology of the peripheral nerves, like say this metabolic stage, which is classical example being diabetic neuropathies. Or you have the immune mediated like Guillain-Barré syndrome or CIDP. You have infections like leprosy, okay, Lyme, etc. Drugs like INH or toxins like arsenic, thallium, etc. You can get mechanical involvement of the peripheral nerves, which may be a mechanical compression or by physical agents like radiation. It can be cancer related, means direct effect of cancer, radiation, or chemotherapy. And it may be hereditary. And if you go through this whole list of etiological factors and you cannot find any etiology factors, then we classify those peripheral neuropathies as cryptogenic, which may be sensory or sensory motor. Now, in a large study in Mayo Clinic by Peter Dick, please remember that if you're very honest with yourself, 25% of peripheral neuropathies may fall into the cryptogenic group in spite of all investigations. Out of those 25%, Dick found out that about 20% of those, if you take a detailed family history, may turn out to be familial neuropathies. Because he is such a large referral group in America, they can get the histories from United States as well as Canada. And they have established that many of these cryptogenic neuropathies may in fact be heredofamilial. Now, the author, first part of this talk by Zachary London is to differentiate between the upper motor and lower motor neuron. I will not test your integrity to go into those details. We will know that peripheral neuropathies are essentially lower motor neurons. Then he talks about focal symptoms, patterns like radiculopathy, plexopathy, and mononeuropathy. But today, I am going to give you what I consider is the 3-6-9 approach. There are three things which come to mind whenever you look at a patient of a peripheral neuropathy. Where is the lesion? What is the lesion? Which we all do in every case where we are taking a history. And in view of the treatment modalities that are available, particularly steroids, IVIG, and plasma exchange, we have to also ask a question, is it treatable? And as a rule of the thumb, I might say that all acquired demyelinating neuropathies are treatable. Most of the axonal degeneration are non-treatable. Therefore, please keep that in mind. Okay. Then we have 6 key questions when taking the history. We keep to ask ourselves. You all are asking all these questions to yourselves, but I would like to just present them in a systematic fashion. And lastly, there are 9 patterns of neuropathic disorders. So let's begin with the first, now 6 questions. You know, the 6 questions are: what is the temporal evolution of the neuropathy? What are the systems involved? What is the distribution of the weakness? What is the nature of the sensory involvement? Is there an associated upper motor neuron involvement? And is there any evidence of hereditary neuropathy? Now let's go to the first thing, temporal evolution. Unlike strokes, where it is practically instantaneous or really acute, acute in peripheral neuropathy means days or 4 weeks, up to 4 weeks. And the classical example has been taken from AIDB. So up to 4 weeks is considered as acute. Subacute is anywhere from 4 to 8 weeks, and chronic is more than 8 weeks. So you all know that AIDP falls into the first category and CIDP falls into the last category, chronic. Also, when you take a history of temporal evolution, you must also ask for some preceding events like upper respiratory tract infection, GI disturbance, etc., particularly in AIDPs. You must ask a history of drugs. And in India, please ask for Ayurvedic drugs, particularly Ayurvedic drugs which contain bhasmas. And bhasmas fall into the toxins like heavy metals. Okay. So this history of toxin may be masked when you ask a simple history, are you taking any Ayurvedic drugs? But you must ask the content of the Ayurvedic drugs. Namely, you must ask for bhasmas and not the biological products. Okay. The second question that you ask yourself, am I dealing with a motor neuropathy, a sensory neuropathy, autonomic features, or a combination of any of those 3? Now, most of the peripheral neuropathies will be a combination of at least 2, motor and sensory. And there may be autonomic features also in some of the neuropathies. Now, this is what I would like you to pay attention to. What are the systems involved? If the motor system is involved, are there predominant motor symptoms on presentation? And if there are predominant motor symptoms on presentation, you must consider Guillain-Barré and CIDP, very common. Lead intoxication or acute porphyria, hereditary motor sensory neuropathy in which the motor component is more. Then MMN, multifocal motor neuropathy, and multifocal acquired demyelinating sensory and motor neuropathy, or MADSAM. MADSAM is nothing but MMN with sensory component. Diphtheria, which is of historical interest essentially, and toxic like dapsone, amiodarone, vincristine due to drugs. All right, now I've kept MMN in yellow and I've outlined it because all these things, MMN is the only neuropathy which is pure motor. There is no sensory component. If there is a sensory component, it moves to MADSAM. Therefore, motor MMN becomes a very close differential diagnosis of motor neuron disease. Now, if there is significant autonomic nervous system involvement, there are a few neuropathies which come to mind. Will somebody switch off that bell, please? If it is acute or subacute with predominant autonomic symptoms, then you consider Guillain-Barré, common, porphyria, uncommon, vincristine induced if it is in a cancer patient, and pan-dysautonomia, which is extremely rare. And if in all my 48 years of practice, if you go about it, I've seen only one case. And it is a variant of Guillain-Barré. All right. Now, what are the features in Guillain-Barré of autonomic features? You all will note that as the bulbar involvement comes about in Guillain-Barré, you will find that the patient has a tachycardia. That is because of lack of vagal inhibition. And as the patient is recovering and coming off the ventilator, you will note that the tachycardia starts becoming less on the monitor. So that is the feature of Guillain-Barré. You can get orthostatic hypotension in Guillain-Barré, which sometimes poses a problem for your therapy with plasma exchange. Now, if it's chronic, please remember diabetes first, diabetes second, diabetes third, fourth, fifth, sixth, seventh, and all the rest can come afterwards. But I will stress on Sjogren's also, a little bit on Sjogren's later on in my talk. The other conditions are basically rare. If the patient is HIV, then you know that HIV-related autonomic neuropathies comes. The diagnosis is easy. Hereditary sensory and autonomic neuropathies requires a few investigation. So Fabry's as well as Sjogren's. Now, what is the distribution of the weakness? Usually the distribution of the weakness is distal, and those are usually axonal neuropathies. But if the distribution of weakness is proximal plus distal, please keep acquired demyelinating neuropathies in mind. Very few can do proximal plus distal. Then, if it is asymmetrical or focal, you have entrapment neuropathies like carpal tunnel syndrome or you have the beginning of mononeuropathy multiplex. Now, this is a slide I like to show. On the right-hand side is a patient who had 90 days of weakness due to a demyelinating AIDP. And on the left, he had axonal AIDP, like Aman. And you can see the degree of wasting at the end of 45 days compared to hardly any wasting at the end of 90 days in the demyelinating. Now, please go back to that cartoon that I showed you on my first slide and keep that picture and this picture in mind. Now, the distribution of weakness in mononeuropathy multiplex. You can get a patchy involvement. One upper limb, one lower limb, opposite lower limb, etc. So what are the conditions which produce mononeuropathy multiplex? Because depending on the etiology, you are going to base your investigations. Diabetes comes first, second, third, fourth, fifth. Okay, but you must remember vasculitic neuropathies. You must remember multifocal motor neuropathies. The first M stands for multifocal. So it may be multifocal along a limb, along a nerve, or it may be multifocal as far as multiple nerves are concerned. In HIV, everybody knows you can get it. Leprosy, I think Dr. Khadilkar is the champion. He will tell you. Lyme, fortunately, is not in India, but occasionally in foreign countries, you may have to consider that. Sarcoid, yes, and herpes can produce herpetic lesions. Okay, so you know all that. And lastly, it's a hereditary neuropathy with tendency for pressure palsies. And I can give you the example of one of my patients who happened to be a Bollywood artist. And when he was doing weightlifting, he developed carpal tunnels from external pressure. And once when he was lying down and his foot or his leg went across the edge of the bed, he developed a foot drop. So he had a tendency for pressure palsy, hereditary tendency for pressure palsy. Okay, now this is one more case of mine. This is taken later on. He first presented with the next slide that I will show you. But you can see that he has got a left lateral rectus palsy. But he presented with pain in the right hypochondrium. And he was thoroughly investigated, including CT scans, ultrasounds, etc. And no cause could be found. Now, if you look at it carefully, there is a slight bulge on the right-hand side. And this was with his necks relaxed. Because I had seen a similar case in New Zealand, I asked the person to just flex the neck against resistance, and you can see the big bulge on this side. This is classical. This is classical for diabetic truncal neuropathy. Okay, I think this screen sharing thing is coming in my way. I don't know. All right, this is classical for diabetic truncal neuropathy. If you see it once, you can never forget it. Now, what is the nature of the sensory involvement? You can get tingling, numbness, paresthesia. This is the classical sensory involvement in the garden variety of any peripheral neuropathy. However, there are some peripheral neuropathies which produce severe pain and some peripheral neuropathies which produce severe proprioceptive loss. Therefore, when you have painful neuropathies, you have small fiber neuropathies. All right? And what are the painful neuropathies? diabetes comes again. Please remember, throughout the theme of peripheral neuropathies, you will find diabetes coming because diabetes is not a single neuropathy, but it's various varieties of neuropathies. And here, the classical example is the burning feet syndrome of diabetic neuropathy, which can come very early in the history of diabetic patients. The second is vasculitic. All of you know that when the nerve infarcts, there's tremendous pain. So you have vasculitic neuropathies producing a mononeuropathy multiplex, which is painful. Now, Guillain-Barré syndrome. Why do I put Guillain-Barré syndrome here? If you examine a patient of Guillain-Barré syndrome and you do a straight leg raising test, they'll scream with pain. They'll scream with pain. And in those patients, the protein content of the CSF will be very high because the nerve root barrier, the blood root barrier has been broken at that point, and therefore the CSF protein goes up, and this inflammation of the roots produces this type of pain. Then drug and toxins like thallium can produce a lot of pain, and INH produces a lot of dysesthesias and painful, very painful. Then HIV-related distal symmetrical neuropathy. This can be so painful that the patients do not even put their foot on the bed sheet. They leave their feet hanging up in the air. It can be so painful. Then alcohol and nutrition, similar to HIV-related distal symmetrical neuropathy. Amyloidosis, Fabry's disease, and Sjogren's disease can also do the same. Chemotherapy. Earlier days, bortezomib was given for multiple myeloma. Nowadays, a variant of that is being given, which produces less amount of painful neuropathies. Thalidomide can produce a lot of painful neuropathies. And some centers are using a lot of thalidomide in the treatment of resistant tuberculosis. And lastly, you can get a cryptogenic sensory or sensory motor neuropathy, which can produce, you have to exclude all this 1 to 8 causes before you say it's a cryptogenic sensory neuropathy. Now, let me show you some of my examples from JJ Hospital. This is a gentleman who had received some form of serum. I think it was a anti-tetanus serum. And he developed severe serum sickness and severe peripheral neuropathy. You can see the wrist drops on bilateral sides. And the vasculature of the periphery also got blocked, and you can see the dry gangrene in his limbs. We managed to salvage this patient by giving him high doses of steroid. Now I come to the favorite of the Bombay Hospital group, sensory neuronopathy, severe sensory ataxia. And the first is, sorry, who's that? The first thing to consider is
somebody's mic is on, and there's a little music also in the background. So if everyone can please switch their mics off. Yeah.
Okay. You get paraneoplastic anti-U antibody syndrome, Sjogren's syndrome. Now here, let me talk a little bit of Sjogren's syndrome. Sjogren's syndrome, the peripheral neuropathy can be a presenting symptom in 85% of the patients with no glandular systemic symptoms. Okay. The varieties of peripheral neuropathy in Sjogren's can be mononeuropathy multiplex. It can be a predominantly distal small fiber sensory neuropathy, and I already told you A Sjogren can be there in painful neuropathies. It can be a subacute or chronic, predominantly sensory neuronopathy. That is this variety. And this is usually seen in elderly women. And additional features with this type of neuropathy may be tonic pupils or a trigeminal neuropathy. So if this combination comes, you can practically make a spot diagnosis of Sjogren syndrome as a cause of severe sensory ataxia. Okay, 80% of Sjogren syndrome peripheral neuropathy will later develop severe autonomic dysfunction, namely bladder and bowel involvement, as well as orthostatic hypotension, etc. And the way to diagnose this is SSB and SSA antibodies. And please remember, SSB is more sensitive for peripheral neuropathies, coming out positive in 75%, where compared to SSA, which is 30 to 45%. Then you have chemotherapies like cisplatin and oxaliplatin. HIV-related sensory neuropathies, idiopathic sensory neuropathies, where we do not know the etiology, megavitaminosis B6 and small. These conditions are basically of historical illness, and I won't go into them because they have come and they have gone. Okay. I think Arnold Schwarzenegger was partially responsible for megavitaminosis B6 because with his success in Conan the Barbarian and all these movies, everybody wanted to build up a body like Arnold Schwarzenegger. And they started going to these gym instructors. And these gym instructors started giving them a high protein diet and loaded them with vitamins. They were taking grams, not milligrams. They were taking grams of vitamin, which included B1, B6, B12. And it is because of the B6 they started developing a sensory ataxia. Once the vitamin was withdrawn, these being water soluble, they were easily excreted in the urine and they all recovered. SMON is subacute myelooptical neuronopathy. Actually, it's not a neuropathy. It's actually Mrs. Wadia had demonstrated a neuronopathy and they had severe sensory ataxias. I think these are of historical interest, not in the clinical things. Now, question 5. Is there an upper motor neuron involvement? If there's upper motor neuron involvement without sensory loss, then it's an asymmetrical distal weakness. You consider motor neuron disease or MMN. And with sensory loss, classical B12 deficiency or subacute combined degeneration, severe liver disease can do it also, HIV can do it, adrenomyeloneuropathy can do it, and lastly, or TOCP poisoning. TOCP was added as a coolant to aviation fuel. And there was an epidemic of TOCP poisoning in Bengal. There's some unscrupulous dealers just washed those barrels with water and then stored the grain or stored oil. And people who consumed that oil developed TOCP poisoning. And I've seen 1 or 2 cases of those in which the upper motor neuron component is the severely exaggerated knee jerks. And the lower motor neuron component is a foot drop, absent ankle jerks. And in some patients where the weakness was relatively mild, we could get extensor plantars. In others, we could not get extensor plantars because the plantars were mute. Now, is there evidence of a hereditary neuropathy? Now, what is the evidence of hereditary neuropathy? In a way, history taking, these are usually chronic, very slow progressive distal motor weakness. They can have recurrent compressive mononeuropathies if they have a hereditary neuropathy with a tendency for pressure palsy. If you look at the feet, they are either flat or high arched and they have hammer toes. And I've made the diagnosis in a young girl of this type of a hereditary neuropathy by asking them a simple question: does anybody in your family have funny feet? And the mother, who had very high heel boots, immediately took her shoes off and said, I have funny feet and therefore I wear closed shoes. I don't wear sandals. And she had hammer toes. So a simple question like that in the history may give you the answers. If you look at the spine, there may be scoliosis, and therefore you have to examine family members. And on the left is my patient from JJ Hospital who had a hereditary neuropathy. Very obvious, you can see the trophic ulcers on the dorsum. And this was his younger brother who had odd toes and a very deformed left little toe. Okay, now we come to the 9 patterns of neuropathic disorders. And I'll begin with weakness and then we'll go on to the sensory components. So the first pattern is symmetrical proximal plus distal weakness with mild sensory loss. And it doesn't take much to say conditions like Guillain-Barré and CIDP. As I told you, if you have proximal plus distal weakness, please consider the acquired demyelinating neuropathies. However, if you have asymmetrical proximal plus distal weakness with sensory loss, you have to consider diabetic amyotrophy. And rarely it can be due to carcinomatosis, lymphomatosis, or hereditary neuropathy with pressure palsy. Now, this is a case of axonal Guillain-Barré. You can see the wasting, extensive wasting in this boy. And this is the gentleman. As you can see, his thigh on the left looks wasted. And if you look closely, there is a scab mark of an injury to the right knee joint. This is the same patient extending his right leg, but he cannot extend the left leg. And now you can see the evidence of injury even to the left knee. This is classical diabetic amyotrophy with distal diabetic symmetrical motor sensory neuropathy. Okay, so please keep that in mind, because just controlling this patient's diabetes and just getting a relaxed euglycemic control, the patient was able to recover. Okay, now we go to the symmetrical distal weakness with sensory loss. This is the garden variety of any peripheral neuropathy. But you can get asymmetrical distal weakness with sensory loss, in which you will consider mononeuropathy multiplex due to vasculitis, MATSAM, hereditary neuropathy with pressure palsy, or infections like leprosy. And you can get asymmetrical distal weakness without sensory loss, in which you consider motor neuron disease or multifocal motor neuropathy. Okay, so now already 5 patterns are over, which leaves only 4 patterns, and those will essentially deal with sensory components. Sorry. Now this is classical diabetic peripheral neuropathy, and this is the sign that we talked about in our paper, which I've written in collaboration with Amit Riddhi and Satish Khadilkar. And this is a diabetic leprosy. You can see hypopigmented anesthetic patch, and this is not a vein, but you can see a very thickened nerve here. Okay, so this is a case of leprosy. So now we come to the patterns in which we are dealing with the sensory component. So you have a symmetrical spinothalamic loss, means temperature, pain, etc. No weakness. In that you get cryptogenic sensory peripheral neuropathy, diabetes, drugs, toxins, and you may or may not get distal areflexia. The most difficult diagnosis here is diabetic burning feet syndrome, in which you get a lot, a lot of pain distally, and the ankle jerks may still be preserved, if sluggish but still preserved. And therefore it becomes very difficult to make a diagnosis of peripheral neuropathy. Now, I think my guys, the postgraduate students from Bombay Hospital will recognize this severe proprioceptive loss, no weakness, but areflexia. The localization goes into a sensory neuropathy, dorsal root ganglion involvement. Okay? Now, you have symmetrical proprioceptive loss, but upper motor neuron signs are added, and therefore it becomes subacute combined degeneration with a neuropathy with distal areflexia. And the last pattern is a very, very rare pattern of only autonomic symptoms and signs, no other evidence of a motor or sensory neuropathy, and that is pan-dysautonomia, very rare condition. I will not talk about it further. Let's omit all this. Now, sometimes you can get neuropathies with skin changes. And please look at the skin properly. If you have purpura or livido reticularis, vasculitis, or cryoglobulinemia, angiokeratomas, Fabry disease, hypopigmentation, leprosy, hyperpigmentation, osteosclerotic myeloma, or pellagra, bulbous lesions, variegate porphyria, and ichthyosis, Refsum's disease. So the skin sometimes gives you the answers to the peripheral neuropathy. I have not added one more condition here. If you get hyperpigmentation, not only osteosclerotic myeloma or pellagra, but you have to keep arsenic neuropathy in mind also. I should add arsenic there. Now, for those uninitiated, I think this patient was one of our patients during my house officer days in neurology, where Dr. Wadia was dealing with nutritional disorders. And this is an alcoholic who replaced all his caloric intake by alcohol. And these are the classical lesions of pellagra, which you will not see nowadays. I don't think you see them nowadays. And this is that same patient whose fingers I had shown. At the end of our treatment, this is the hyperpigmentation that was left behind because of dry gangrene. Now, neuropathies with hair or nail changes also can give you. And the classical example is measlines with arsenic, thallium, or lead. Alopecia, thallium. Curled hair with giant axonal neuropathy, and white nails and clubbing with osteosclerotic myeloma or with Poems syndrome. Okay, and this is the classical arsenical measlines. You can see the thickness of this because this female patient was being fed arsenic for a long time in her food by her in-laws, husband and in-laws. So you can see the thickness of the measlines. Okay, Satish, I can stop at this stage because it's a clinical
Yes,
approach.
sir. Yes, sir.
I can stop at this stage because I think I've taken 5 minutes extra.
Yeah.
Okay.
Right, sir. So, shall we open the presentation for discussion? If there are
Yeah.
questions from anyone, they're most welcome. Any questions for Dr. Katrak? I think it was such a beautiful presentation, very, very clear as to how to go about the history and examination. Any questions?
If you say it was very clear.
I just want to say that this is one of Dr. Katrak's 3 great presentations, which I mentioned a few years ago when we gave him the so-called send-off.
Yeah.
Approach to peripheral neuropathy, art and neurology. And the 3rd great presentation he has got is eye and neurology. If you listen to this, it'll stay with you till the last day of your practice.
Yeah.
It's absolutely incredible.
It's not eye and neurology, it's unexplained visual loss.
Yeah, okay.
Yeah.
Absolutely phenomenal. Yeah.
An approach to unexplained visual.
It's absolutely a treat on a Sunday morning.
Thank
No,
you.
but this 3, 6, and 9 approach is really excellent. You can just slot it, and then really, it eases off it streamlines the diagnostic process.
No, I'll tell you an incident regarding this talk. I first gave it in NIMHANS.
Yes.
And in those days, there were slides.
Yeah.
At the end of my talk, Dr. D. Nagaraja approached me and said, "Sir, can I have your slides? Because the postgraduate students have asked for slides. So can I duplicate your slides?" I gave it to him. And he duplicated the slides and returned my slides. Many years later, I again took the same lecture at NIMHANS. Satish Chandra approaches me. "Sir, can we have your slides for duplication?" I said, "But I had given them to Dr. Nagaraja." He said, "Oh, you know, sir, how he is." I don't know what they do as teachers there, basically. I don't know whether they share it with their students or not, which was...
Sir, actually, in your practice, what percentage of neuropathies you would think are difficult to put a label on? I would think it's pretty high.
No, I'll tell you, it's pretty high. And therefore, I said, if you are honest with yourself,
correct.
What happens is that you take a history and the person is taking moderate amount of alcohol. The postgraduate student puts it down as an alcoholic peripheral neuropathy. And the label sticks. And you don't proceed to investigate the patient further.
I think B12
my point
diabetes leprosy.
Yeah. My point of stressing is the hereditary neuropathies is that they were very often missed in the Indian scenario.
Correct.
Because we do not know our family history. And as I mentioned earlier, sometimes the families are taken from the father's side only. The mother's side is totally neglected.
Correct.
So many of these X-linked, say Fabry's, etc., may be totally lost. Secondly, I think we must know the full spectrum of peripheral neuropathies due to diabetes. And I have taken a talk only on diabetic neuropathies. See, for example, the truncal neuropathy that I showed.
Yes.
Was going from pillar to post, being investigated, all sorts of things.
Correct.
Where nobody bothered to find out.
See, has anyone in India, in any medical college-like setting, has done a inpatient and outpatient analysis of the neuropathy that visit them in the clinic or in the ward? The spectrum will be different. What comes to the ward, what comes to the clinic will be different.
See, in the wards they have done, because there Guillain-Barré comes on top.
Correct.
The admitted inpatient peripheral neuropathies essentially become Guillain-Barré.
Guillain-Barré cancer and advanced diabetes.
Although no lymphoma, odd ones, lymphomatosis, cancer related, etc. But the true true nature should be outpatients. We
There is
hardly
some.
see the change in pattern is so obvious now that we used to see a lot of alcohol and nutrition. And let me also make a mention that Dr. Darab Dastur used to do estimation of B1, B6, B12 separately, you know. And many of these patients who came in, the nutrition was so bad, that the stupid diet of JJ Hospital improved their whole neuropathy. No, it's not a laughing matter.
Yeah.
So alcohol I can understand, but sometimes we used to
The
get
type of
patients
diet.
with nutritional neuropathies, starvation
Yeah.
neuropathies.
Yeah.
I think Dr. Praveena Shah has joined. So, ma'am, welcome. Good morning.
Thank you.
Good morning. So,
Okay,
shall we?
so
Are there more questions,
yeah.
or shall we move on to the next one?
Sarosh, I remember these cases of Darab Dastur.
Yeah,
I used to bring
I
cases
have
from KEM.
no, I'll tell you. There's another story about Darab Dastur and me about this. You know, I had to collect the blood, and every time I collected the blood as a house officer and send it to Darab Dastur, remark in red line, hemolyze, blood sample hemolyzed. So I went up to him. I said, sir, how is the blood sample hemolyzed? I'm taking all precautions. He says, no. And he fired me left, right, and center. He said, those days there were those re-sterilized glass syringes and needles.
Syringes.
Yeah. So he says, I want a bone dry syringe. I said, sir, how do I get a bone dry syringe? So he showed me. You take the syringe and you start pumping the piston.
Acha.
Then take it out, again shake it, again pump it, again take it out, shake it. And one day I was just doing this, and Dr. Singhal suddenly came on the rounds watching me. What are you doing? I had to say, sir, I am trying to get a bone dry syringe. And he had a very good laugh.
Terrific.
But that is the way we learned and whatnot. Then when I collected the blood, it was not hemolyzed. And I got the report.
Fantastic. Fantastic. Fantastic.
Yeah. So
Yeah.
let's
Okay,
go
I
on
think
to the next one.
Great.
Actually,
Thanks.
this
Wonderful lecture.
the chapter that I'm going to take the inherited neuropathies. The chapter comes later in the continuum, but I had to bring it up because there's another meeting coming up, and Jimmy and Ashok will take charge of the continuum after 11:30. So I'll share my screen.
I'm sorry, we've got practically an hour in this.
No, sir. That's that way we have time today.
No, but it was worth it.
Right. So after this fantastic lecture by Dr. Katrak, let me take you to the Shakumari 2 and other inherited neuropathies. The chapter is written by Christopher Kling, who seems to have done a lot of work in the subject and works at the Mayo Clinic. Now, this is a rather difficult topic for people to grasp, because there are so many types and subtypes and genes and everything. So pay attention to the first few slides, where I think I will discuss the approach, and then the details of which gene where can be looked up in whichever text you want to. Now, I have taken reference of the continuum material. I've also taken a reference of the patients that I've seen. I've also taken reference of one manuscript that we wrote on inherited neuropathies, and some other bits and pieces of the MRI work which we published some time ago. So what will we discuss? See, firstly, the topic is very big, and if you look at the heading, it is CMT, which is also used interchangeably with HMSN, hereditary motor sensory neuropathy, and other things. So the discussion largely will be CMT, and then there will be discussion on other forms. So really, what is the breakup? The first few slides, as I said, are most important. The breakup of inherited neuropathies is primarily HMSN or CMT, which forms the bulk of the cases. Then there are pure motor forms, hereditary motor neuropathy. Then there are largely sensory and autonomic forms, the HSAN. Then there are episodic forms, which are HNPP and hereditary brachial plexopathy. And then you have a whole host of conditions where neuropathy is part of a larger neurological syndrome. So basically, when inherited neuropathies come to your mind, it is a motor sensory neuropathy. Some will be pure motor, few will be sensory and autonomic, and then episodic, and then neuropathy may be a part of a larger sort of neurological disorder. So that's the basic format of what I will be discussing. So as I said, the Charcot-Marie-Tooth disease, or HMSN, forms the bulk of inherited neuropathies. So we will take them first. As you know, in Paris, Salpêtrière, Charcot, and Marie, both of them worked in the same hospital, and Tooth in London in 1886, around that time, gave the first description, what they called peroneal muscular atrophy, because they wanted to emphasize the distal nature of the problem. A few years later, Dejerin and Sota described another disease in children with a hypertrophic interstitial neuritis. So from 1886 to 1968, a good 80 years, it was peroneal muscular atrophy or Charcot-Marie-Tooth disease. And that's how it sort of got entrenched into the literature so well. Now, in 1968, Dick and Lambert went a little beyond the clinical features and used electrophysiology and said demyelinating, axonal, and intermediate. Then came the genetic advances, and that sort of revolutionized and complicated everything. Now, this chapter does not discuss the role of MRI neurography, but I have put in a few slides pertaining to that. Right. So when you see a neuropathy and you want to know whether it's a genetic neuropathy and how do you go about it, what are the fundamentals of evaluation of genetic neuropathies? I think firstly, as a clinician, you divide them into two. Is neuropathy the primary process, or is neuropathy part of a wider clinical spectrum? That's the first step that you take. And part of the wider clinical spectrum, you've got ataxias, you have leukodystrophies, you have got mitochondriopathies, you have inborn errors of metabolism, and a whole lot of other groups. So that itself is a very large chapter, where neuropathy is part of a wider clinical spectrum. Now, if neuropathy is a primary process, which is our focus for today, we go through the following steps. History and clinical examination, as usual. Focus on the pattern of transmission where we can. Then we go to electrophysiology, then we go to neuroimaging, and then we go to the NGS data. That's how systematically one would go through these steps. So the first step is history and examination. And the question you ask yourself, is this a genetic neuropathy? So what are the pointers? Some of which were mentioned by Professor Katrak in his lecture. A very long history. And by the virtue of being very long, it is hidden. So it is important to go back and back and back and see how far back you can go. And it's not unusual for a seasoned neurologist to go on asking questions and realize that in college life, the person was not okay. In school life, the person was not okay. The early developmental milestones also were slightly delayed. So to establish the duration of the illness, you have to really go on asking probing questions. How were you at school? In the 100-meter race, were you towards the back of the pack? Are you a physical person? There are so many of them say, oh, look, I am a computer person and I am a desk person. I've never participated in sports. So the duration, that's what you concentrate on, and for which you need to ask various milestones along their age. Now, why is it important to know the duration of the history? One, to see how long the illness is. And in neurology, as you know, anything longer than 10 years is likely to be a genetic disease, whatever part of the nervous system is affected. So you need to know how long the disease has been. And also it helps you a little bit further because the axonal forms in general present later than the demyelinating forms. So if somebody started off with the problem as a very young child, the chances are that the electrophysiology may show a demyelinating process. So you're building a little on that. If you have a large family, then you examine as many as you can, because like has been mentioned again and again, some families consider pace cavus and gait changes as their family traits, and they do not think them to be diseases. Like they may say, oh, we always all have walked like that, when they all actually have a pace cavus. Another point to remember is that in the history, the symptoms pertain mainly to the weakness, and sensory symptoms often do not appear in the history. But when you start the examination, you are very surprised as to how much is the sensory involvement. Then you go back and ask history and you may still not find much. So lack of positive sensory symptoms and then tremendous findings is another clinical pointer towards an inherited process, though it can also happen in leprosy. And then you examine carefully for pes cavus, hamartose, kyphoscoliosis, and thickened nerves. So as a guideline, if you have a neuropathy with a skeletal problem of whatever sort, you are dealing with an inherited process. So just like there is skin plus nerve, eye plus nerve, whatever the pattern that Dr. Katrak mentioned, skeleton plus nerve is likely to be inherited. And thickened nerves. I think it takes a lot of practice to really be sure whether a nerve is thickened or not. And I think it's a good idea to keep practicing on patients in whom there is no neuropathy as well, to really get a feel of what is a thickened nerve. In clinical practice, a lot of the times you will find firm nerves around the ulnar, around the lateral popliteal in people who are doing a lot of physical exercise. And they're not necessarily thickened. Normal nerves are supposed to be soft. In older adults and older individuals, they may become naturally firm. People who exercise, they become firm, but they hardly ever get thickened. So this is just a recapitulation of the common skeletal and phenotypic forms that you see. If you look at the lower limbs of this boy in sitting and standing position, you will see the way there is a distal wasting, and in mid thigh the bulk starts coming up, the so-called inverted champagne bottle appearance, and the pes cavus and the hammer toe, which you see on the right of the slide. Now, quite often, yes, sir.
Many postgraduate students have seen a champagne bottle.
Yeah, yeah, it's like the dive bomber. It's like the dive bomber, at least for me. Yeah.
So I think we'll have
So
to
it's the
change our.
yeah. It's the long, thin segment and then the bulk form. That's the constellation. Now, the pes cavus and the hammer toe. On the right side, you see pes cavus and you see the hammer toe. The hammer toe is that sort of deformity. So often, when the toes are turned outwards or inwards, sometimes students call them hammer toes, but hammer toe is this. as you see in this picture. Now, as far as pes cavus is concerned, pes cavus can be bony or pes cavus can be muscular. So the best position to examine pes cavus is when the leg is dangling and not in a weight-bearing mode, like you see this boy sitting on the bed at the JJ hospital. This is a bony pes cavus. If this boy stands, the pes cavus will still be there. But if there's a muscular weakness, wasting, and an appearance of pes cavus, then when such a person stands, the arch will flatten out. And the way to test is to put a battery from one side and see whether the torchlight comes from the other side to know that both arches are, or the footprint that you can see. So inverted champagne bottle appearance, pes cavus, hammer toes, sometimes kyphoscoliosis. These are the skeletal abnormalities that you see. So what are the clinical points at the end of history and examination that you do look at? You of course look at the skeleton and in the neurological system. So when did the disease begin? If it's early, it may be demyelinating. Which fibers are clinically affected? Motor, sensory, and autonomic. Accordingly, you're going to slot it into HMSN, HMN, or HSAN. So that's the second point. Are the nerves thickened? Again, demyelinating. And are there any other clinical pointers? Besides the general constellation of skeleton, when the disease has started, what the disease has affected, and are the nerves thickened, which is the basic format for all inherited neuropathies, you can have additional telltale signs. And these I have taken from the neuromuscular book that we wrote in 2018. So you can see the left column, forget the right column. You can see the left column, there can be specific features like macular degeneration, optic atrophy, glaucoma, cataract, tonic pupil, facial and bulbar weakness, hearing loss, tongue atrophy, vocal cord, diaphragm, and so on and so forth. Kyphoscoliosis also comes below this. So it is important to be aware that in addition to the basic format of genetic neuropathy, there may be these telltale signs which may take you to a particular group or a particular genetic abnormality. Therefore, in a given case, after having categorized it into HMN, HMSN, HSAN, and possibly demyelinating or axonal, one should see whether any of these exist, whether it can give you a clinical clue. So that's the first step, history and examination. Then you add electrophysiology to it. And this is Dick and Lambert's work in 1968, which subsequently has remained more or less the same as far as the categorization is concerned. So median motor conduction velocity less than 38 meters per second is demyelinating. Axonal is more than 38 and intermediate is around 35. That's how they have classified it. And various studies subsequently have held this in good stead, so it's continued. So the 38 number has come from statistical evaluation of their data. So second step is, what is the electrophysiology? Is it demyelinating? Is it axonal? Is it intermediate? Now, once you have done that, this table becomes a little relevant. That what are the general differences between axonal versus demyelinating inherited neuropathies? Demyelinating are first decade. The foot and the spine deformities are more prominent. They are areflexic from early time. They tend to get tremors or polymania myoclonus or whatever you may call it. Their nerves are thicker. And axonal are later in onset. Deformities are less prominent. Reflexes may come in the early phase. Tremors are less prominent if present, and nerves are not thicker. So up to that point, one can reach after these two steps, clinical and examination, electrophysiological examination. Then comes the genetic transmission. And I think this is where another important step, that diseases can be autosomal dominant, diseases can be autosomal recessive, diseases can be X-linked, mitochondrial, and others. Now, in this category of genetic neuropathies, it is largely a dominant transmission. So according to the genetic transmission, these diseases got classified. First clinical, then axonal demyelinating, then the gene. So the gene has classified it like this. HMSN1, which is used more or less synonymously with CMT1. So HMSN1 or CMT1 is a dominant demyelinating process. HMSN2 or CMT2 is a dominant axonal process. So as you can see in world literature, 90% of the patients are dominantly transmitted, more often demyelinating than axon. Now, in our situation in India, because consanguineous marriages are more common, the recessive diseases are not, the number is not as low as 10% as the world literature says. And there are some Asian studies which say that up to 30 to 40% may be recessive. So at least 60-70% will be dominant in India. So you have to really look at the family tree. So we draw the family tree. If it's dominant, more often than not, you will find it in the family tree because dominant diseases go dominantly. Now, HMSN3 is currently stands for all recessive diseases. Though the term was started for the Dejerine-Sota disease, presently all, presently I'm so sorry, HMSN4 stands for recessive. Initially started for Repsum disease. So all others also are now included recessive. So HMSN1 is dominant demyelinating, HMSN2 is dominant axonal, HMSN4 is all recessive. Now HMSN3, the term is now not used because the categories that originally came in HMSN3, which was for the Dejerine-Sota disease with very, very slow nerve conductions. We know that there are various genes that do that, and they have been absorbed in HMSN1, 2, or 4. So currently there is no HMSN3. 1 is dominant demyelinating, 2 is dominant axonal, 4 is all recessive, Refsham disease and all others. Then comes HMSN-X or CMT-X, which is X-linked recessive. Now 5, 6, and 7, I have put them in red because they are associated with other neurological conditions, and the frequency is very low. So for a neurologist sitting in his consulting room trying to analyze the genetic neuropathies, it is 1, 2, and 4 and X. So just to recap, 1 is dominant demyelinating, 2 is dominant axonal, 4 is recessive, and 5 is X-linked. Now that's reasonably simple, I think. So clinical, electrophysiological, genetic. Then comes the NGS. In the last 20 years, the NGS has given literally, as I was reading, over 800 now. Over 800 genetic defects of various types are known within this category of diseases. So they started by saying CMT1, go A, B, C, D, E, F, G, according to the causative gene, as they went on finding, just like they have done in limb-girdle dystrophy and most genetic disorders. CMT2 started with A, but has reached Z already. So they are falling short of the alphabets. So they want to start A1, A0, A1, A2, like that. But the NGS has created more information and more problems. What are the problems? 2 I have highlighted here. The same gene, example I'm taking of the MPZ gene, which is the second most frequent after PMP22, can have a dominant demyelinating, which will become CMT1, and B, because that was the second gene detected. Or it can also present with an axonal, which will then become CMT2I or J, and it can also present as recessive. So here is one disease that this is something similar to adrenoleukodystrophy. It can be dominant, it can be recessive, it can be X-linked. So here you have dominant demyelinating, dominant axonal, and recessive. So what are you going to do now? Where are you going to put this? So MPZ gene has posed this problem. Second example I'm taking is the NEFL gene, which can be transmitted as a dominant axonal, which was previously called 2E, and a recessive demyelinating called 4F. So these two examples highlight that a single gene abnormality can behave differently in different families, and therefore the framework that you created up till now, which was clinical examination, electrophysiology, and then transmission, the NGS has produced more problems. So what is the current state? The current approach, which was given by Matthews and colleagues in 15, it's not so new, but it's not so old either, which says we go like this. We work on 3 modules. One is a generic term. Is this an HMSN? Is this an HMN? Is this a HSAN? Module 1, which is clinical. 2 is what is the electrophysiological type? Axonal demyelinating intermediate. So AXDEIN. And the mode of inheritance, ADARXL. And then the causal gene name. So they propose, say, let us take example of the common PMP22 deletion. It will become CMT from module 1. It will be autosomal dominant AD. It will be demyelinating, so DE. And the NGS shows, not NGS, the multiplex PCR shows PMP22 deletion. So the nomenclature will be CMT, AD, DE, PMP22. So you have taken into account all your 4 parameters: clinical features, electrophysiological features, inheritance, and the NGS data. And this currently is the most logical way of classifying the CMTs. Now, once you say there are about 800 different genes known in this category, there's absolutely no point in remembering them. You have to clinically decide between CMT, HMN, HSAN, do the electrophysiology in, say, axonal demyelinating intermediate. What is the inheritance if you can establish this? In all cases, you may not. And then you just add the gene name to the thing, which I think is the best approach as we stand today, taking various axes into consideration. Now here, let me take you through this table a little bit, that some acquired demyelinating neuropathies look very similar to inherited neuropathies. So what are the real differences? Most inherited neuropathies are very, very slow. That's why we go back to the history. When did the process start? And here I think I will give one example which I which I always give. One Sri Lankan man came to my consulting room with a facial palsy. And he said, I have come to Bombay. I have developed this facial weakness, but you please admit me because I have got CIDP. So because he was a foreign national and he wanted an admission for a facial weakness, also he was brought into the hospital. Next morning when I was on the round, I crossed Dr. Lal Kaka and I said, look, I have a patient of CIDP for 23 years. She says, 23 years has to be a genetic neuropathy. And to cut a long story short, that actually was a PMP22 deletion with a HNPP-like situation. So slow diseases versus not slow diseases. Almost always, they go from distal to proximal when they're inherited. I will show you one example of reverse, but they go from distal to proximal. Whereas most of the acquired, proximal comes pretty early, or it may start proximal and go both. And because they are slow, wasting and weakness goes hand in hand. But in the rapid ones, weakness is much more than wasting in some of them. Now, in inherited, sensory signs are grossly more prominent than the symptoms, and symptoms as well as signs in acquired ones. Then other family members affected, skeletal deformities, and then you come to electrophysiology. That's uniform conduction slowing in CMTs, whereas you will see multifocal conduction slowing dispersion in the acquired ones. CMT-X being an exception. Now we'll come to the MR neurography, about which there is very little in this chapter, but I think MR neurography has really come out to be one nice way of corroborating that the nerves and plexuses are thickened. And here is one example of a inherited neuropathy with gross thickening of the lumbar roots. Now, the role of histology. With the advent of NGS, like in everywhere else, histology has become less and less popular and less relevant. But if and when in a given case you do it, which usually is when you're wanting to exclude a leprosy or exclude an amyloidosis, then you see the onion bulb appearance. And this was a patient who had a chronic neuropathy in his family, and somebody had sent us the biopsy from Ahmedabad. And there is a very good pathologist in Ahmedabad by the name Dilip Jethwani, who had reported this as onion bulb, and it turned out to be an inherited on the NGS as well. So the role of biopsy is actually gone to the research settings. Right. There is very little data available on inherited neuropathies in India. There is some data being produced by NIMHANS, which is a large-scale data, and I was a PhD examiner for that thesis recently. And once they publish it, that will be a very good data. There are literally more than, I think, 300 patients that have been analyzed. So we put together a pilot study of very few patients. But what did we find? We found PMP22, which is the commonest, then GJB1, which is CMT-X, then SS3TC2, and then 111 of each type. Now, in one of these patients, this I'm putting up as a curiosity. In one of these patients with a PMP22 deletion, there was a grandmother, mother, and son. Son was the index case. And anticipation is known in CMTs. So this family with every generation was becoming more severe. And here you see the mother's MRI. And here you see the son's MRI. So clinically, they became more and more affected. Their nerves also became more and more thick. This is so-called radiological anticipation. Right. Now, does the MRI differentiate inherited from acquired? Some time ago, we showed reasonably large data of 130 odd patients of various diseases. And Dr. Jaggi and Dr. Sonali Shah tried to put together the differences between inherited and acquired. And the top plates are CIDP patients and the bottom plates are HMSN patients. And they think that there are some features that they can think of to try and differentiate. But at this point in time, I would say that one has to put everything together to make a composite diagnosis. And MR may give you a little lead towards acquired versus demyelinating by way of contrast enhancement, by way of the way the thickening is. But one should not depend too much on a single investigation. Now I will take you through a few cases. This is a 20-year-old girl with a pes cavus, hammer toe, born of a consanguineous marriage, and clinical symptom was a gait change over 5 years. She had extremely severe kyphoscoliosis. Now, somehow in this figure, it's not coming out that much, but it was much more than this. And she had a sensory motor areflexic demyelinating neuropathy. So what have we got here? We have a sensory motor neuropathy. So it's a CMT. So our first module is CMT. It was a demyelinating disease. So it is CMT DE. She was born of consanguineous parents and no other member was affected. So it is more likely that it was a recessive transmission. So CMT, DE, AR. And then when we did the gene studies, it came out to be a particular gene called SS3CT2, which is also a gene that was common in the Bangalore study, which is yet to be published. So early onset demyelinating recessive CMT4. So CMT4, because it's recessive, CMT4, ARDE, and this gene mutation. That is how we would classify. Now, this girl has very early and very prominent kyphoscoliosis, which is one of the special markers in that list. And that is known to be associated with this gene. So, early onset demyelinating recessive with kyphoscoliosis, we hit upon the gene. And this happened 3 or 4 times subsequently as well. So, if you see a lot of kyphoscoliosis in our situation, in recessive transmission, it turns out to be the SS3CT2 gene. Right. Now, this is a second case, 20-year-old girl with subacute progressive proximodistal weakness of all 4 limbs and sensory ataxia, which was, according to her, only 2 months duration. Maybe I'll skip this case because I think it will open up for another story. This is a patient with an inherited neuropathy who worsened very rapidly and with a likely pathogenic defect in the MFN2 gene, worsened tremendously, and with solumedrol improved again. So, I mean, this is something that we have discussed earlier, and if there is time, we can discuss again, that some inherited neuropathies have acquired part on top of them, and this case actually was for that particular reason. So, case 3 is a 56-year-old male. This is quite an unusual case. It's a 5 years duration of insidious onset, slowly progressive, asymmetric, proximal, upper limb onset, proximal, sensory motor, lower motor neuron type of weakness. And he has a long history of muscle cramps, fasciculations, and polymini myotones. So just to recap, proximal, somewhat asymmetric, upper limb onset, largely motor, with a long history of cramps and fasciculation. And the family tree showed that it was autosomal dominant. And you could get it in 3 families. 5 males and 2 females were affected in 3 generations on the paternal side. And in addition to the neurological features, which were slightly asymmetrical upper and lower limb proximal weakness, neurogenic tremor of outstretched hand, there was a little gynecomastia. So actually the diagnosis considered at that point in time was Kennedy disease. But the 2 female members affected did not make sense because Kennedy disease is an X-linked recessive, as you know. So we thought of some familial anterior horn cell disease clinical, and we thought of Kennedy, but the genetics did not fit. Electrophysiology, however, even though he had no sensory symptoms and no sensory signs, showed absent snaps in the lower limbs as well as the upper limbs. And there was a sensory involvement, electrophysiology. So what looked clinically like motor was sensory motor on electrophysiology. So it was sensory motor, it was proximal, it was a middle-aged presentation. So frankly, we didn't know what it was. And the processing was done, NGS processing was done for a familial disease about which we did not really know which one will it turn out to be. And the report suggested that this is the Okinawa hereditary motor and sensory neuropathy. So the final diagnosis is HMSN-P, proximal dominant. So you can have an occasional case where the problem clinically presents proximally. This I am showing as an exception. The rule is distal. So the EDX was suggestive of sensory motor. Now, Okinawa neuropathy is largely described from Japan, and Okinawa is the place where it was described from. But sporadic cases are described from other places. I am not aware whether there is any Indian data, but I suppose now that the genes are there, There will be data. Right. Now, the next case is a 16-year-old boy who was taken to a physician in a small town in Maharashtra because he was falling easily and the boy was, into inverted commas, weak, and he was not getting stronger. So the physician asked for an EMG nerve conduction study to sort out the problem. And NCV was reported to show a demyelinating neuropathy with conduction blocks and dispersion, and it was done by a very reliable person in that town. So the physician gave short course of steroids, which did not help. And these were the tracings, and here you can see the dispersion very, very clearly, and the conduction blocks. With this sort of thing, because he did not improve, he came to Bombay. He had very few symptoms, and they were non-specific, like toe ache, and I can't run, and I don't enjoy physical activities. And on getting into the family tree, so many members were affected. And you can see that all the male members in the 3 generations are affected. And the boy actually had a pes cavus. And the bottom plate shows the maternal grandfather. And this is another relative, I forget exactly who it is, who also had the pes cavus. So obviously, we were not dealing with an acquired condition. But this condition, the patient had pes cavus, hammer toes, firm nerves, areflexia. And if you see the electrophysiology, there was decreased motor amplitude in legs, and velocities were in the demyelinating range. So you had a patient who looked like an inherited neuropathy. Only males were affected, and the electrophysiology was like an acquired neuropathy. Now, this is the typical situation of CMTX, which was proven in this patient. So the point to remember in CMTX is that the electrophysiology looks like acquired demyelination. Now, nobody knows why that happens. But this I have now seen at least half a dozen times, that a diagnosis of CIDP has been made based on the electrophysiology, even though the clinicians have wondered what this is. And it turns out to be CMTX. So we have seen CMT1, we have seen CMTX, we saw a CMT4, and we saw one Okinawa type, which is HMSNP. So that was about the Shakumari 2 or HMSN. Now, in the next few minutes, HMN, hereditary motor neuropathy, sometimes called the DHMN, because these patients are largely distal. And because they are largely distal, slowly progressive, symmetrical, distal, they look like a distal SMA. And electrophysiology shows distal prominent denervation. And the differentials are distal motor neuron disease or a distal myopathy. As you start off this situation, these are very uncommon. And I don't think we have genetically proven cases beyond 1 or 2. And a whole lot of DHMN are still genetically unproven. Then is the HSAN, where the brunt is on the sensory system and the autonomic system. And here is one of our patients, and you can see the gross mutilation of the lower limb, very early presentation in life, and even the tongue has been bitten because of insensitivity to pain. So sensory and autonomic nerves are affected. These patients have much greater morbidity and mortality because the sensory system is so badly affected. Mutilations occur, and sometimes autonomic features also occur. Then HSAN is again classified according to the transmission and according to the gene. I think we should know a little bit about HNPP, and Dr. Katrak alluded to it in one of his cases. This is one of the common clinical presentations. The first attack comes in second or third decade. There's a painless focal weakness and sensory loss, incomplete but substantial recovery. And if it starts early, it doesn't seem to go too well. And there is a 1.5 MB deletion in the PMP22 gene region. Now, one point for postgraduate students to remember is that this is diagnosed by multiplex PCR. This is not diagnosed by NGS. And this is also the commonest neuropathy in the genetic neuropathy range everywhere, and also probably in India. So when you are wanting to look at the problem, and first you want to send the gene, if it's demyelinating, if it's dominant, send PMP22 gene, which is a polymerase chain reaction multiplex PCR. And then you got this other inherited neuropathies, where neuropathy is a part of all other diseases. And secondary to inherited metabolic disorders, leukodystrophies, hereditary ataxias, mitochondriopathies, and all others. So this is where the phenotype will be very different, and neuropathy will be just a part of it. And I will show you one or two examples. This is one of my patients with cerebrotendinous xanthomatosis. And you can see here where the arrow is, a very large xanthoma on the tendo-Achilles, and the changes in the dentate nucleus. This is from the paper on analysis of dentate nucleus, which we had put together 5-6 years ago. Now, this is Fabry's disease, where you get the skin lesions, and the skin lesions are around the umbilicus, around the buttock area, below the scrotum. So you have to know where to look for the Fabry's disease lesions. And this patient was already sent to us by the dermatologist with a diagnosis that this is Fabry's disease. And the patient also had small fiber neuropathy and a stroke event. Now, last case I will show, second last case. So I will go over quickly. This was a patient with chronic progressive external ophthalmoplegia, sensory ataxia, areflexia, and extreme cachexia. He was so cachectic that his great auricular nerve and the ulnar nerves you could see from outside. So extreme cachexia, sensory ataxia, areflexia, ophthalmoplegia. CSF protein 58, CSF lactate grossly elevated at 39, electrophysiology showing a demyelinating neuropathy with uniform slowing, and an MRI showing white matter changes of extensive nature, as you can see. So, for want of time, we'll cut this. This actually patient was thought to have the Menge syndrome, mitochondrial neurogastrointestinal encephalopathy. Now, at this time, we did not have the NGS, so we sent the thymidine kinase levels. There is a doctor called Michio Hirano, with whom Ichizo Nishino worked earlier. And he shifted to United States. He did it for us and showed that it was low. Subsequently, there have been 2 more patients in whom this diagnosis was proven. And both of them had then NGS proof of the diagnosis. Lastly, I'll show an 8-year-old female, delayed motor milestones, gradually progressive distal proximal weakness, younger brother having the same problem. And here I think the giveaway is the hair, tight curly hair. This is giant axonal neuropathy, which was subsequently proven on the NGS. Right. So we have seen this large number of conditions, how to differentiate them, how to categorize them, how do they present. Unfortunately, in spite of a lot of knowledge in terms of NGS, the management and surveillance still remains very, very supportive, depending on what the patient has got. Genetic counseling plays a tremendous role because we have to prevent it from going ahead. Patients have to do exercises. Correctly tailored ankle foot orthosis helps their gait for a long time. HSANs are particularly bad, and therefore you need to teach them how to take care of the painless wounds, and we have to make sure that osteomyelitis doesn't come in. When the skeletal deformities are very gross, surgery can be considered for them in selected patients. There is a lot of literature on different things being used for different pathophysiological mechanisms. For PMP22, there are trials of ascorbic acid, progesterone, sorbitol, with some benefit being shown in the statistical designs. For GJB1 mutations, viral vector delivery has been successfully tried in rodents. And like everywhere, antisense oligonucleotides are being tried for a variety of these conditions. So to conclude this presentation, inherited neuropathy spectrum has expanded tremendously with gene discoveries. A systematic approach with history and examination, transmission, electrophysiology, MRI studies, sometimes a biopsy, and NGS can categorize them very well. HMSN forms the bulk of the conditions, followed by HSAN and HMN, then episodic forms, and then there are neuropathies associated with other diseases. The present management, however, remains supportive, and we have to still say that newer therapies are in development. So I'll stop there, and I think we can take questions if there are any. So I'll stop the sharing. Yeah.
I think Satish,
Yes.
this was one of the most lucid and comprehensive talks on CMT.
Thank you, sir. Thank you.
Very frankly, that I have heard.
Good.
Considering that there are 800 genes.
Various genes. Yeah.
You have, you know, the last time I read about this topic, it was about 18, but that time next generation sequencing was just coming into the picture.
I think it
And
just
I think next
expanded
generation
everything.
sequencing,
Yeah.
you know, exponentially the number
Absolutely.
of genes that have been described.
Absolutely.
But the take-home message is that 95% of these cases will belong to those 5 genes.
Correct.
PMP22 deletion,
Yeah.
PMP22 point mutation,
Duplication. Yeah.
MPZ,
Yeah.
BJB1, and
Yes.
MFN2.
Yes.
95% of the cases.
Correct. Correct. And the same may hold true in India. Yeah.
PMP22 will be the main one.
Yes.
So I think the
And
postgraduate students should really look at type 1, type 2, autosomal
yes.
dominant DMAP, and I think the X, CMT-X.
X. Yes.
If they master that, I think 95% of the cases they will get right.
Absolutely correct. Yeah.
All
And the
these,
approach. The approach
rest of the
clinical, then
cases,
yeah.
yeah. And I will send you the slides of one of my family of tendinous xanthomatosis,
Yeah.
in which I did the MRI of the tendon.
Lovely.
And it's intense.
Hmm.
It shows the cerebellar, dentate nucleus, and I've done the MRI in sagittal as well as axial cuts.
Hmm.
And it shows up like a nice block, you know, behind the calcaneum.
Lovely.
So I'll send those slides.
Yes,
I'll
sir.
send
Yes,
those
sir.
slides to you.
Thank you.
You know, basically. Yeah. But I enjoyed your talk very much, you know.
Thank
Is it part, this is from mainly from your book?
Yes, sir. The from the book.
Neuromuscular.
Yes, sir. Yeah, and some of the other work. Yeah.
Yeah.
Sir,
Right.
good morning, sir. Rakesh here.
Good morning,
Hi.
Rakesh.
Sir, excellent talk, sir.
Thank you.
So
Satish,
just
One
I
of the
want to ask.
finest, one of the
Sorry.
finest talks that I have listened
It's a
to. I mean, it is
complex
so
topic.
comprehensive, and you know, taking it right from the basics and going down to the most you know, advanced things. Really fantastic, Satish. Wonderful.
Sir, just wanted to ask.
Yes.
Few patients had lot of neuropathic pain. I mean, in as a part of CMT, how common is that, sir? Severe sensory complaints.
I mean, it's not much in the literature, and but from time to time, there are people in whom you wonder about acquired diseases maybe coexisting. Yeah,
Yeah.
there is a small number of people who give this sensory symptom, but I don't know what that is.
Rakesh, did those patients have any autonomic features? Because small fiber and autonomic are
Yes, sir.
in close proximity to each other.
Yes, sir.
And
Yes, sir.
question that I wanted to ask Satish,
Yes.
many of the associated symptoms like optic atrophy, deafness, with your peripheral neuropathy are features which you see in mitochondrial
Mitochondria,
disorders.
particularly deafness. Yes.
Yeah, deafness and
Yes.
optic atrophy.
And optic atrophy. Yeah.
Combination of that with peripheral neuropathy.
Absolutely.
But you describe those findings in many of the cases
The
with your
CMTs.
autosomal.
Yes. It seems to be one family description, few family descriptions. So it's more the point that there may be other features to look at. But then if you find one, then you have to go back to the book as to where is it described in which families, because there's just so much there.
Fine.
So we go to the next one.
Still around?
Sorry.
I thought she would be in Canada by June.
Who?
Asad, you didn't allow her to go.
Sir. Yes, sir.
You're still around, or are you talking from Canada?
Sir, the flights have been suspended till 21st August, so I have not yet booked my flight, sir.
I think
I'll let you know.
Asad had some hand in that. Huh?
I'll inform you also before I leave.
Fine. Nice to hear your voice.
Thank you, sir. It was a wonderful talk, sir. Both of you all had it was like a Sunday treat. Your talk on neuropathy and Dr. Khadilkar's talk on CMT.
Thank you.
I think this is the NHW Gharana talking. I think it's the inheritance.
Inherited ability to deliver lectures of this nature.
No, I don't know whether it's autosomal dominant or X-linked. All males are involved.
Yeah, so let's go to the third one now. Diabetes and metabolic disorders and peripheral nervous system. Dr. Abhijit along with Rakesh. Rakesh, thanks for joining and thanks for taking the time to do this. Yeah. So Abhijit, share your screen, please.
Good morning to everyone. I will start my sharing.
Yes.
Yes, sir. Is my slides visible, sir?
Yes.
Yes. Good morning, everyone. Today's my talk is on diabetes and metabolic disorder and peripheral nervous system, guided by Dr. Rakesh Singh, sir. Diabetes, India is being the diabetes capital of the world. In 2020, according to the IDF, almost 463 million people have diabetes in the world, and India carries almost 77 millions of the diabetes amongst them, and prevalence calculated to be the 8.9%. It has been predicted that up to the 2020 there will be almost 100 million people in India will be living with the diabetes, and it is prevalence more in urban as compared to the rural populations. Coming to the complications of diabetes, as Indian population has been found to have the more pronounced insulin resistance, again, though there is a higher waist circumference despite of the low body mass index, and there is a higher risk of inflammatory markers in Indian population that leads to the multiple complications of diabetes. That most commonly found is nephropathy, and the prevalence of the diabetic neuropathy is not known because of the most of is found to be almost 32%. But this prevalence is how it is differ from study to study, because most of the study focus on the particular type of the diabetic neuropathy. Again, there is a difference because of the multi-ethnic and the multicultural populations. And again, the autonomic neuropathies that again get unnoticed in most of the studies. So the calculated prevalence of diabetic neuropathy comes to be the 32%, almost approximately. The diabetic neuropathy is diagnosis of exclusion. The type 1 diabetes is considered to be linked directly with the glycemic control, but type 2 diabetes is not found to have the direct link with the glycemic control, rather than the individual component of the metabolic syndromes that contribute most of the part of the diabetic neuropathy rather than the glycemic controls. After all forms of the diabetes over the period of time will have the diabetic neuropathy as a complications. Considering the diabetic neuropathy prevalence in type 2 diabetes, the patients of the type 2 diabetes who are well controlled diabetes will develop 42% of the population will develop diabetic neuropathy over the period of 10 years, as compared type 2 diabetes who are poorly controlled will be having the 68% of the prevalence over the period of very fast, that means over the period of next 4 years. Why we should so worry about the diabetic neuropathy? Because it's often get unnoticed. 50% of patients can be asymptomatic without presence of pain. Again, there are major complications that contribute to major morbidities such as foot ulceration, gangrene, limb loss. There is increased risk of amputations. There is 17-fold of increase of amputation in patient with the diabetic sensory neuropathy. It increases to 12-fold if there is a deformity associated with neuropathies, and it increases to the 36-fold if there is history of any previous ulcerations. There is estimated that diabetic neuropathy account an amputation every 30 seconds globally. It will also lead to the falls and the fracture because of the involvement of the large fibers that causing motor problems or the sensory ataxia causing falls and the fractures. Again, autonomic neuropathy being the one of the vulnerable factors that contribute to 20 to 50% mortality within the 5 to 10 years of the onset. Coming to the pain is the most common morbidity associated with the diabetic polyneuropathy. It hampers the quality of life. Again, it produces the poor sleep. Again, cause depression, anxiety. Which are the risk factors for the pain in diabetes? Female sex, more advanced neuropathy, patient who is having the poor glycemic control, and the impaired renal dysfunction. Coming to the pathophysiology of diabetes, there are many other mechanisms have been proposed. The base of the pathogenesis is oxidative stress that's come because of the hyperglycemia and hyperlipidemia that causes the inflammatory stress on the system, causing the mitochondrial dysfunction, energy production failure, and causing the axonal transport dysfunction and causing the axonal degeneration. There are 5 categories that has been proposed, that is 5 types of diabetic neuropathy that we see. First is lane-dependent axonal polyneuropathy, that is most common, and it contributes almost to 50 to 70% of the chunk. Second is the acute diabetic neuropathy that mainly includes, first is diabetic radiculoplexopathy, that is diabetic amyotrophy, and second is treatment-induced diabetic neuropathy. Third is mononeuropathies. Fourth is autonomic neuropathies, and fifth is increased risk of CIDP in patient with diabetes. Coming to the just topographical presentation of how the patients with DPS is present, the common presentation will be the lane-dependent axonal sensory motor neuropathy that present in the Stocking-Low distribution, can have the large fiber type or the small fiber type. If patient is having the large fiber type, patient will be having the more motor complaint, less sensory complaints, and the diminution of the proprioceptions with absent of the reflexes. If the patient is having small fiber type of neuropathy, patient will be having minimal sensory loss, thermal allodynia, presence of pain, but motor, but power and the reflexes will be the well present. Proximal motor neuropathy present can have the proximal motor weakness, deficit will be more, less sensory complaints. Patient can have the acute mononeuropathies and can have the intraapparent neuropathies. We will see one by one. First is distal symmetric polyneuropathy or diabetes, that is DSPN. That is most common. It constitutes almost 50 to 70% of the diabetic polyneuropathy. It preferentially involves the small unmyelinated axons with the involvement of the long fiber over the period of time. So the clinical presentations will be distal, bilateral, symmetrical, and stocking of glove distribution because of the lane-dependent pattern. There will be the nocturnal exacerbation, the sensory symptoms more than the motor complaints, and they're associated with the minor motor weakness. It does not occur only in the type 2 diabetes, but it also occurs in the pre-diabetic test and the patient with the metabolic syndromes. The pathology behind this is dying back neuropathy. That is different from the neuronal remodulation, where there is the selected fragmented degeneration that occur because of the glial cells that act as a phagocytic cell, and there will be the regrowth because there is the preserved growth factor signaling. But in case of dying back neuropathy, there is dynein activity will be reduced. That causes dynein dynactin complex interference abnormality. So there will be the reduced growth factor signaling. So if there is any insult, there will be no regrowth. There will the gliosis happen, and after that that leads to the cell death. So coming to the treatment factor or DSPM, there is no any disease modifying therapies available. The treatment should be focused on the modified risk factors such as the glycemic control. That will be very helpful in the type 1 diabetes as compared to type 2 diabetes, because in type 1 diabetes, glycemic control can reduce the diabetic polyneuropathy prevalence to almost 78% as compared to type 2, where type glycemic control can reduce the complication of diabetic neuropathy only up to the 5 to 7%. And the neuropathic pain management, mainly by the GABA analogs such as the pregabalin, gabapentin, TCS such as the amitriptyline, or the selective serotonin norepinephrine receptor inhibitor such as the duloxetine. Coming to the acute diabetic neuropathies, that contains the two types. First is the lumbosacral radiculoplexus neuropathy, also called as diabetic amyotrophy, and second is treatment-induced neuropathy of the diabetes. Considering the lumbosacral radiculoplexus neuropathy, it's commonly occurring in middle-aged patients with type 2 diabetes. Prevalence is more in men as compared to women. The asymmetric that will present with asymmetric proximal motor neuropathy with hip, back, and knee pain with associated weakness and wasting that preferentially involves the hip flexors, quadriceps, and the adductors. There will be loss of knee reflexes. There is presence of weight loss, and the proposed mechanism is immune-mediated epidural microvasculitis, so that this neuropathy can sometimes respond to the steroids also, but study is not proven. There will be the progression over the period of 18 months, and another 12 to 24 months will be required for the recovery. When should we should think of the box when patient is develop motor deficits that affect the proximal distal muscles, and NCS is predominantly demyelinating. That time CIDP, MGSS, or the vasculitis should be on card. Now the second entity in acute neuropathy is treatment-induced neuropathy. As we see in this graph also, as there is a greater decrease in the HbA1c, the risk of the developing the risk of developing treatment-induced neuropathy also increase. So acute onset of lane-dependent neuropathic pain will appear that especially involves the small muscle fiber. There will it is associated with the rapid improvement of the glycemic control in patient with the chronic hyperglycemia. It usually begins 2 to 6 weeks after the change in glucose control. And as small muscle fibers are mainly involved, the patient may present with the autonomic syndromes. The mechanism that is proposed behind that is there is a relative hypoglycemic state because of the rapid decrease in the sugar and the glycemic control. There can be a reflex pro-inflammatory cytokinin release that causing the axonal damage. Again, the severity of the treatment-induced diabetic neuropathy correlated with the magnitude and the rate of change in the HbA1c. Patient can get renal and the retinal complications. Renal complication is most common is the microglobulinemia, and the retinal complication most common being the proliferative retinopathy. It suggests that the pathology is some diffuse pathology. There is no any recommendations how should we tackle this situation, but author says that we should limit the change of HbA1c to the 1% reduction per month. Coming to the fourth type, that is focal neuropathies. Most common are the entrapment neuropathy that is seen in diabetic patient as compared to the general population. Patient can get the median entrapment, ulnar entrapment, or the popliteal entrapment neuropathies. Again, the focal neuropathies can also present with the extraocular muscle dysfunction in form of third, fourth, or sixth, or sometimes seventh muscle involvement. Coming to the third one, focal neuropathy associated with diabetes, diabetic truncal radiculoneuropathy. It affects the middle age to elderly type 2 diabetes. Patient always present with the pain like girdle-like distribution that is especially involves the lower thoracic abdominal wall. Though motor weakness is not common, but can sometimes patient can present with the pseudohernia, and they can be mistaken as the abdominal hernia. There will be a resolution in this situation over the period of 4 to 6 months. Coming to the autonomic neuropathies, it is the most serious and the common complication of the diabetes, and especially contribute to the death in the patient with the diabetes, especially if the patient is having cardiovascular autonomic neuropathy. But it is least recognized and unnoticed. The symptoms generally do not appear until the long after the onset. It can occur subclinical in type 2 and type 1 patients also, more early in type 2 as compared to type 1. Consider the different type of autonomic dysfunctions. Coming to the most common is cardiovascular. We have to very vigorous in notifying the changes. Patient can have the central autonomic dysfunction that comes with the resting tachycardia. Patient can have bradycardia, arrhythmia because of the vagal denervations. Patient can get the orthostatic hypotension because of the denervation of the sympathetic efferent autonomic system that precipitated with the decreased exercise tolerance. Again, patient can develop the paradoxical supine nocturnal hypertension. Coming to the gastrointestinal autonomic dysfunction, patient can present with the esophageal dysmobility, gastroparesis that is very common because of the autonomic dysfunction. There will be the emptying the gastric delay. Patient can develop the diarrhea, especially patient will be having the nighttime profuse watery diarrhea. Patient can come with the constipation or sometimes the fecal incontinence. In the genitourinary symptoms with autonomic dysfunction, that can be erectile dysfunction, especially the early morning erectile dysfunction. Patient can have the retrograde ejaculations, neurogenic bladder. The patient will come with the urgency, hesitancy, or something urinary incontinence. And the female diabetic patients can get the sexual dysfunction because of the loss of the glandular dysfunctions. The pseudomotor autonomic dysfunction, patient can have the loss of anhidrosis, loss of sweatings, hyperhidrosis that can cause heat tolerance, and more common in diabetic patient is gustatory sweatings. The metabolic autonomic dysfunction that can present with the hypoglycemic awareness or the hyperglycemic awareness because of the blunting of the sympathetic counter-regulatory responses. Coming to the management, the cardiovascular autonomic neuropathies can be managed with the supporting garments, as if the patient is having a postural hypertension. Remove the potential aggravating drugs, which are the drugs we'll see in the next slide, and antioxidants, and the AC inhibitor has to found the reduce the odd ratio of the autonomic neuropathy to 0.2%. We should control the sugar levels. Again, the component of the metabolic syndrome has to be addressed, such as the hypertension, obesity, again the dyslipidemia. We should target those also. And some drugs are available for the orthostatic hypertension, such as the fluorocortisone, clonidine, octreotide. The GI problems, autonomic gastrointestinal problem, can be mop up with the multiple small meals. Again, patient we should advise him low fiber with decreased fat intake. Some drugs are advised, such as the metoclopramide is the FDA approved for the gastric paralysis. Again, other drugs are domperidone, erythromycin, or ghrelin receptor agonist. Now, coming to the genitourinary autonomic dysfunction, for the sexual dysfunction, we should advise withdrawal from the alcohol or the smoking or any additive drugs, removal of the potential drugs, and the drugs for the erectile dysfunction, such as the sildenafil or the tadalafil, can be helpful. The patient with the cystopathy, we should improve the bladder improvement. Credis maneuver can be applied where we apply the pressure or the lower abdominal pressure to facilitate the urination, or some drugs, cholinergic drugs such as the bethanol or the doxazosine. And the self-catheterization should be advised in the patient who is having the significant post-white residue. For the pseudomotor dysfunctions, we should avoid some food that elicit the gustatory sweatings. Food care is very essential, and the low dose of the oral glycopyrrolate can be given to the patient who is having the pseudomotor dysfunctions. For the patient who develop the metabolic autonomic dysfunction because the hypoglycemic unawareness, we should relax the therapy. We should not be very so hard in chasing the glycemic control, because more the glycemic control, the patient will be having the more episode of the hypoglycemia, and that cause the more lower threshold of the detecting the hypoglycemia and mounting the sympathetic autoregulation. So we should not target the glycemic control in type 2 diabetes. Again, the long-acting insulin with very small boluses can be effective in such patients. There are some of the medications that author has described in his article that we should avoid in the patient with the autonomic dysfunction. As patient with the orthostatic hypotension, with the potential causative factor should be removed, such as the antidepressant, antihypertensive medications, antiparkinsonism, dopaminergic agents. Patient with the gastroparesis, we should avoid the opioids, clonidine, tricyclic antidepressants, calcium channel blocker, and the dopamine agonist. The patient with the constipation, calcium channel antagonist, opioids, and anticholinergic medication should be avoided. Diabetic diarrhea, metformin, sorbitol containing food, we should be very cautious regarding that. In the patient with bladder dysfunctions, anticholinergic agents, TCAs, and the calcium antagonist, we should avoid. And the patient with sexual dysfunction, antidepressant, antihypertensive medication, and statin, we should avoid. Coming to the risk for the chronic inflammatory demyelinating polyneuropathy in patient with diabetes, it is debatable. Some articles have reviewed that there is almost 7 to 9 times more risk of developing CIDP in patient with diabetes, but some argue with the same statement. So it is very important to see whether it is DSPN, that is diabetic sensory polyneuropathy, or it is CIDP, or it is CIDP in patient with the diabetes. There are some differentiating points we should always think of. First, the clinical presentation. The clinical presentation is the DSPN, that is a distal sensory polyneuropathy of diabetes, will be having the early small muscle fiber involvement, and patient will present with the pain, dysplasia, and numbness, and that will progress over the period of almost 1 to 2 years. But patient with the CIDP and diabetes will be having symmetrical proximal distal muscle weakness. There will be predominant large fiber modalities affection. There will be loss of proprioception, loss of vibration, the greater motor complaint as compared to the sensory deficit, and there will be rapid progression over the period almost over the next 8 weeks. The electrophysiological study in DSP will show the sensory motor polyneuropathy. There will be mild slowing of the nerve conduction velocity with the normal latency. As compared to the CIDP and diabetes, we'll be having the nerve conduction velocity to less than 70% to the lower limit normal, and latency will be to the more than 150% of the normal, and the conduction block will be more than 50% in at least two nerves. The histology can again give some clues to the diagnosis. In patient with the DSPN, the histology will show the myelinated fiber loss. There will be the reduction in the unmyelinated axon density and the diameter, and the endoneural microangiopathy. Histopathology in CIDP with diabetes will be having the demyelination and the remyelination, like onion skin, the like appearance, with characteristic epineural perivascular T cell infiltrate that will be the immunoreactive positive for the MMP9. The treatment modality, because the differentiative between two is main regarding the treatment, because DSPN will require the symptomatic treatment, and there will be the chance of improvement with glycemic control. But the CIDP, the intravenous immunoglobulin will be the first line therapy, and patient who is refractory to that, we should go for the plasmapheresis. Coming to the evaluation in patient with the diabetic polyneuropathy, the bedside evaluations carries the high weight. We should check for the vibration with 128 hertz of tuning for pain with the neurotips or the Wardenberg's wheel. Pressure should be checked with 1 gram and the 10 gram monofilament. Light touch should be checked with piece of cotton, and cold should be tested with the cold tuning forks. There are some verified scales so that we can weightage the severity of the diabetic neuropathy. First, we will see that Michigan's neuropathy screening instrument that constitutes the part A and the part B, where A part is constitutes the 15 questionnaires regarding the symptoms of the patients. That means how is the symptoms, how is the burning sensations, whether he has any history of any ulceration or the amputations. And the second part is physical assessment, whether again it is given the 10 points, right and left has to be checks separately. And here we'll see the appearance of foods, presence of ulceration, and the clinical findings such as the anti-reflexes, vibration perception at the greater toe, and the monofilament test. Coming to the next one, that is scale is modified neuropathy symptom score and modified neuropathy disability score. As the name suggests, modified neuropathy symptom score will consider the symptoms of the patients. The symptomatology we should consider, where the more weightage is given to the burning sensation, numbness, paresthesia, localization. If the feet, it carries 2 points. If there is exacerbation present at the night, that carries points, and the symptoms aggravating and the relevant factors. The score more than 1 point is defined as the positive for the PNP, and the 3 to 4 score, it suggests the mild symptoms, 5 to 6 suggests the moderate symptoms, and 7 to 10 suggests the severe neuropathic symptoms. Coming to the modified neuropathy disability score, here we will assess the right and left separately, and we will accept the clinical findings. Here we will assess the vibration perception threshold with the 128, temperature perception on the dorsum of foot, pin prick sensation, and the absence of the Achilles tendons. According to it, that will be scored, and severity will be interpreted as 3 to 5 will be the mild neuropathic deficit, 6 to 8 will be the moderate neuropathic deficits, 9 to 10 will be scored as the severe neuropathic deficits, more than 6 there will be the increases of foot ulcerations. Coming to the quantitative sensory testing in the patient with the diabetes, the testing pressure perception is very important. It should be tested with the 10 gram of monofilament. It is having the very high sensitivity from 86 to 100%. Here we test with the monofilament till this monofilament bends, and this monofilament we have to keep for at least for the 1 second. We have to test the heads of the first, third, fifth metatarsal and the plantar surface of the distal phalanx. And for test to be negative, at least 7 of the 10 applications a patient should recognize. Coming to the nerve conduction study in patients with the diabetes, it is found that nerve conduction abnormality in the lower limb increased from 8% to the 42% over the period of 10 years of the illnesses. The patient with the diabetes having the sural and peripheral nerve conduction velocity diminished by the 2.8 and the 2.7 respectively over the period of 5 years. Patient with the poorly controlled incidence of the NCS abnormality in patient with the poorly controlled will be the 40% as compared to 60% in patient with the good glycemic control. As we know that first affected is small and unmyelinated nerve fiber in the early stage of diabetes that will not pick up on the NCS. So we'll need some other objective evaluations such as the quantification of the intraepidermal nerve fiber density. Intraepidermal nerve fiber density loss in the small fiber neuropathy will be the again a clue to the diagnosis of the diabetic neuropathy in the early stages. The loss of, as we see in this also, there as compared to the control, there in the metabolic and diabetes neuropathy, there is a loss of cutaneous nerve fiber that stain positive for the GPG 9.5, that is antigen protein gene product 9.5 in the metabolic symptoms as well as diabetes. Other non-invasive process are the pseudo scan, where it measures the ability to switch the glands to release the chloride ion in response to the electric stimulation on the palms and soles. another non-invasive method is corneal confocal microscopy. That is again the rapid non-invasive surrogate marker for the small fiber damage. It also measures the corneal nerve fiber density and the corneal nerve fiber length. That will correlate with the both increasing neuropathic severity as well as reduce IENFD, and that detects earlier stages of nerve damage as compared to the intraepidermal nerve fiber density. Some take-home message that we should remember: diabetic neuropathy is common complication with diabetes. It carries significant morbidity and the mortality. There's the 5 common presentation we should remember about the diabetes neuropathy, and there is a different measure that there is a different scale that will measure the quantitatively the different type of defects so that we can target our therapies. Still, there is a need to validate and to standardize more tests for the diabetic polyneuropathy. Just in next 2 minutes, we'll cover the next some metabolic neuropathies. But coming to the uremic polyneuropathy, it's the distal sensory motor polyneuropathy. It is more because of the uremic toxins. Patient will early stage patient will present with the paresthesia followed by weakness and the atrophy. There will be severe axonal degeneration in most distal nerve trunks with the secondary segmental demyelinations. The severity and duration of the renal failure will decide the prognostic factor, and the early and the timely patient will require early and the timely chronic dialysis. Renal transplantation has been found to have the most successful method to prevent the neuropathies. Coming to the neuropathies with different vitamin deficiency, vitamin B12 deficiency is very common, especially in patient with the strict vegetarians or the patient with the pernicious anemia, whether it will target the large fiber sensory with and can have the presentation of the myeloneuropathy. Patient will be develop the cortical spinal tract signs as well as the cognitive impairment. Folate deficiency will be having the same presentation as the cobalamin deficiency. Copper deficiency occurs in malnutrition state or the zinc toxicity. That will again target the large fiber neuropathy and can have the presentation of the myeloneuropathy, where a patient can have corticospinal tract involvement, neutropenia, and the microcytic anemia. The thiamine, that is more common deficiency, occurs in the alcoholic patients, bariatric surgery, or secondary to malabsorption. Here the large fiber sensory motor fibers will be targeted. Patient can have the polyradicular neuropathy like presentations. Most common complication be the Wernicke's encephalopathy, Korsakoff syndromes with the neuropathic presentations. Pyridoxine toxicity can occur with the alphenazide alcoholism. Excess of the pyridoxine will be having the presentation like the sensory ganglionopathy. Here the small fiber with large fiber will be involved. Coming to the next metabolic neuropathy is porphyria. It occurred because the enzymatic defect in the biosynthesis of the metalloporphyrin. It will present with the classical triad of the abdominal pain, psychosis, and the neuropathy. Patient most of the time will be having the GBS-like presentation and can be confusing. NCS will again suggest the axonal polyradiculopathy or the neuropathy. And the pathology is proposed to be the neurotoxicity because of the elevated level of delta aminoleucinic acids. And it is again the very treatable causes. Thank you.
Thank you. Thank you, Abhijit. Rakesh, you want to make your comments before we throw it open?
Yeah, it was a fairly extensive coverage. And sir, I just wanted to highlight one point. This
Yes.
Examination by this 10-gram monofilament, because that assessment of light touch is considered to be an important thing to prevent ulcerations. It is more important than checking the pinprick sensation. We often tend to check only the pinprick and tend to sometimes avoid this light touch, and especially this 10-gram monofilament. I think that should be added.
So it
when
should
we
be
examine.
used. That's
Yes, sir. Yes, sir.
Correct.
Yes, sir.
Correct.
I just want to say one point of Abhijit has the incredible art of taking one slide and putting in an enormous amount of data into it. And I saw that in the last time when he made it on the acute stroke, acute coma, critical care neurology This time also he has taken multiple facets of diabetic neuropathy. In one slide, he has given all the clinical data. It's an amazing ability he has. I thought last time was the fluke. Now I know he does it. He's got an art to do it. He's incredible at it.
Yeah, slides were very good.
The question I have is a little complicated. In the last 3 years since this data has come out for treatment-induced neuropathy in diabetes, how often do you see it? I've been looking for it and never really found it, never really satisfied myself and said that this patient of mine has got a treatment-induced diabetic neuropathy. I never understood that. How do you prove it? How do you go about it? How do you suspect it? You look for it and then you say, can it be treatment-induced? How do you go about it? How do you do it?
I'm borrowing the answer from one diabetologist. I was recently in a forum where there was a diabetologist on the forum, and this question was asked to him, and this is how he answered: that when a patient is diagnosed diabetic or is told that, look, your sugars are not doing well, and a certain scare is put into his mind, he goes very hard on all that is suggested to him, which includes diet, which includes the medication. And the other factor he mentioned was the target HbA1c. That some of the modernities suggest that the target HbA1c should be quite low. And to achieve that, they overdo. And he said that these are the people who are likely to go into a treatment-induced neuropathy. In my practice, I have seen it from time to time, but this is the setting that they go very hard at it. Their doctor goes very hard at it, and the neuropathy seems to escalate where sugars become okay.
So I suppose what you mean is that, when the sugars were high and HbA1c was very high, there were no neuropathic symptoms. And then when it really crashes down and, when you would expect the symptoms to be minimal, you actually have an exacerbation of diabetic symptoms.
Correct.
Neuropathic symptoms.
Correct. Exactly.
If Ashok remembers, I said for diabetic amyotrophy, I said he was treated with a relaxed euglycemic control.
Correct.
I use that word.
Yeah.
A slightly relaxed euglycemic control. I have seen several patients who have overreacted to the diagnosis of diabetes.
Correct.
I can distinctly remember one patient. She went for a removal of a sebaceous cyst below her left breast. And as part of the routine checkup, she had a blood sugar done, which was found to be over 400. And being a very intelligent and highly placed executive, he went overboard with her diet and with her diabetic control and developed what is known as a diabetic cachectic neuropathy. All I had to do to her was to make her aware that her control of diabetes was overtly strict, and a more relaxed control of her diet and a more relaxed control of her diabetes would take care of the whole thing. And sure enough, she put on weight and the whole symptoms disappeared.
Right. Excellent.
So I think the way to tell them is, please have a slightly relaxed control of diabetes. Don't overdo it. At the same time, please don't underdo it. Okay. Secondly, I think to answer Rakesh's question, I think this filament, 10 grams filament, is basically a research tool similar to the quantitative sensory assessment. I don't think that in day-to-day practice, any one of us does all these filamentous processes. Dr. Noshiratia used to do that in his leprosy patients, where they were studying foot ulcers, etc. And the same can be applied to diabetic patients. Okay? But for the postgraduate students, the best fine touch is not with a cotton wool or a 10-gram filamentous process. But in clinical practice, it is touching the patient with your finger. Because that is the most physiological fine touch. Please remember, just now Ashok scratched his left cheek. So that's physiological. You're touching your cheek or you're touching a baby to feel the silkiness of the cheeks of the baby. It's fine touch. And day to day, we utilize this fine touch for day-to-day perception. So what is the use of cotton wool and all these filamentous processes is a slightly artificial mode of testing, which is meant in, I think, quantitative assessment of sensations. Okay, but in day-to-day clinical practice, Rakesh, do you ever use that?
Sir, one of the company fellow had given me this 10-gram monofilament, and but I fully agree. I've been using the cotton or maybe touch and not really frequently this 10-gram monofilament.
We never use it. We never use it in clinical practice. I think we use the pin. Okay.
Yes. Yes.
That is one for painful pain. Yes. But for fine touch, I think it is more physiological to use your fingertip.
Yes, and ask absolutely.
Sensations are like.
Absolutely.
Okay.
Yes, sir.
We go to the next one now. GB syndrome. Dr. Siraj Khan with Dr. Ashok Shirsat.
Dr. Siraj is a postgraduate student from Hinduja Hospital. What I found about him is the incredible speed of grasping and coming up with slides. Now, he has prepared this from Guillain-Barré syndrome from the book. And also, he's been able to bring out some more contemporary issues on day-to-day practice in the world of today. So, Siraj, can we start sharing our slides, please? Please begin, Shiraz. Shiraz, you're muted. Shiraz, you're muted. Please put up your volume, please. Shiraz, please put up your volume.
Unmute yourself, please.
Yeah, unmute yourself, please. You're muted.
I think lower left-hand corner, you have that mic sign. Please unmute yourself.
Yeah, hello. Dr. Siraj is disconnecting now, and he will reconnect. Meanwhile, please start Dr. Harsh's talk so he can rejoin. After Siraj is Harsh. So could Harsh please start his talk, and then Harsh, could you please log on? Harsh, are you there?
Yes, sir.
Yeah. Harsh, please start your talk, and Siraj will join after you because he's disconnecting and then he's reconnecting. All right? So he will talk
Okay,
after
sir.
you. Will that be okay?
Yes, sir.
Yeah.
Yes, sir. Sir, visible and audible, sir?
Yeah.
Yes. Yes.
Yes, sir. Good afternoon to all participants. So today's my talk is on CIDP, chronic inflammatory demyelinating polyradicular neuropathy. Before we go into the details, I would like to throw an outline. So we'll cover in three halves. First half would be CIDP, and from now onwards till next 20-30 minutes, when we say CIDP, it means a typical form. Approximately 50 to 60% of the whole spectrum of CIDP cases are in typical form. So a large number of around 40 to 50% are falling into the categories of either variants or mimics. Most of them are CIDP variants. So in typical CIDP, we'll cover prevalence, clinical features, diagnosis and treatment, mainly the newer aspects and practically important points. Then the second half, we will discuss about CIDP variants, mainly MedSem, DEDS, CISP, CIMP, or what we call as CISMP or CISP plus, focal CIDPs, pure motor and pure sensory CIDPs. The bracket percentage are contributory factors or contributory percentage of that particular entity in the whole spectrum of CIDP. So if we make a total, it contributes to almost half of the percent of the CIDP cases, which falls into the category of variants. And then we'll see some of the CIDP mimics, mainly AIDP, other chronic demyelinating neuropathies outside the spectrum of CIDP, monoclonal gammopathy, and some of the other specific mimics of CIDP which we should consider while making the diagnosis and management of CIDP. So starting with the first half, which is typical form of CIDP, it was first described by Dick and colleagues. Now the prevalence based on different literature, the figure varies, but it is somewhere around 1 to 10 in most of the literatures. So according to the Rajabali Wire Muscle Now literature, I am quoting the prevalence as 1.97 to 5 per 1 lakh. Now the difference in prevalence is based on the different diagnostic criteria used. We'll talk in more detail about the diagnosis in next few slides. Typical CIDP pattern we all know. So now we know that 50 to 60% of all CIDP spectrum falls into the typical category which we know. Most of them are adult onset and male predominant. Usual pattern when we start suspecting is the symmetric proximal and distal weakness with areflexia. And in terms of sensory involvement, we see predominant large fiber sensory loss compared to the small fiber involvement. The progression is also very important to define the term CIDP. So gradual progression with clinical nadir reached at least after 2 months is a definite CIDP pattern, as we saw in the previous lectures also. Now, when we talk about the clinical pattern, 60% fall into the category of chronic, continuous, or more or less stepwise progressive course over the period of 2 months, 3 months. Some of them, around 1/3, are in relapsing remitting forms, and some may have a monophasic phase also. Now, acute CIDP. So this particular term we have not included either in CIDP variant or CIDP mimic, because the CIDP variant, they present in a different clinical pattern, whereas acute CIDP term is more in terms of temporal evolution of the progress of a typical pattern of CIDP. So acute CIDP will also present with a symmetrical proximal distal weakness with areflexia, but the progression is quite rapid and hence confusion with the typical AIDP or Guillain-Barré form. This can be seen in up to 18% of cases of CIDP. Now, usually we tend to differentiate it from AIDP based on the temporal evolution. So whenever a patient initially presents to us, we may feel that it is a case of AIDP, and then later on, based on relapsing and remission, we feel that now the patient is falling more into the category of CIDP. But we do have some of the initial presentation that favors CIDP compared to AIDP. So what are they? So in terms of CIDP, whenever we find acute CIDP presentation, autonomic, respiratory, and cranial nerve involvement are not as frequent as what we see in a case of AIDP. So a patient who presents with symmetrical lower limb followed by upper limb weakness in a very acute sort of period, but if he has significant autonomic involvement, respiratory dysfunction, bulbar involvement, or other cranial nerve involvement, he or she is more likely to be in the spectrum of AIDP compared to CIDP. Now, when we talk about the diagnosis, there are a number of diagnostic criteria given in different literatures, and Continuum article also mentions that at least 15 different criteria are there in the publications. Most accepted is the European Federation Neurological Science or Peripheral Nerve Science criteria. Most important part among these criteria to focus on is clinical pattern, which is the most important first clue, and second is electrophysiology. So typical or atypical for CIDP variants that we'll cover later, clinical features plus evidence of clear demyelination in at least two nerves or probable demyelination in two nerves with at least one supportive feature. So supportive criteria comes next. An important thing here is that the CSF that we do is not an absolute criteria for diagnosis of CIDP, and this is more relevant in terms of a typical CIDP case that we observe with clear-cut demyelinating feature. CSF is mainly to rule out the mimics or secondary causes of CIDP rather than to establish the diagnosis. Other supportive criteria are MR neurography, as we have seen in previous lectures, sir has mentioned. Now biopsy, the role of biopsy is slightly getting on a lower aspect now. And response to immune therapy is one more supportive criteria. Now I would like to stress here, response to immune therapy is very important. Sometimes after giving IVIG or steroids and plasmapheresis, and when the patient does not respond, so one of the supportive criteria has not been fulfilled, then it is a very important clue in itself that we start suspecting that he may be a case of CIDP variant or mimic, and we should reconsider the diagnosis. What is important in electrophysiology is multifocal demyelination. Again, not a very continuous pattern of demyelination, which is more classical for an inherited pattern. Along distal, intermediate, as well as proximal segments affecting both sensory and motor system. Now, this is important that we are dealing with multifocal demyelination, which will affect distal as well as intermediate as well as proximal segment in a typical case. Some of the patterns that we'll see later on, such as that, the demyelinating pattern would be limited to the distal pattern. Some of the other patterns, such as CISP, I'll talk more in detail about those patterns, will have demyelination limited only to the proximal segment. So whenever there is multifocal demyelination in all segments affecting both sensory and motor system, it is a classical case of CIDP, and sural sparing pattern, hence proving non-length dependent pattern in acquired demyelinating cause. What is important in CSF, albuminulocytological dissociation, we all know. Now protein, levels of protein in sometimes some of the typical patterns we see more than 100 also, and in some pattern it may be slightly
Harsh, I
raised.
think
So
in between
very high protein levels.
Harsh, in between the thing gets broken off. Just see your connection.
Connectivity. Okay, sir. Now, are you able to hear, sir?
Yeah.
Okay, sir. So when we
So
talk about
CSF.
yes, sir. So in CSF, what is more important is raised protein in CSF and in a very high amount favors typical CIDP as well as sensory. So what this means that in other subtypes such as motor CIDP or other atypical variants, CSF protein may not be as high. But more important than this is in a typical case of CIDP, to establish the diagnosis, suppose we go on for CSF findings, and if the cells are more than 50, it does not rule out CIDP, but in fact it is a very important clue that we should search for the secondary causes. HIV, sarcoid, lymphoma, and leptomeningeal carcinomatosis are some of the important diagnosis when CSF shows high amount of cells in a pattern which we clinically suspect as CIDP. So this was about the classical diagnostic pattern. Now we do have some other diagnostic modalities also. MR neurography we have already seen. As we can see in this picture, the left and right upper pictures. The left one is of the MRI brachial plexus and the right one is of the lumbosacral plexus. We can see the thickened symmetrical enhancement as well as contrast enhancement bilaterally symmetrical in the proximal nerve roots. This is the pattern that we see in MR neurography. And as Khadilkar sir already told in his lecture, sometimes MRI may be of use in differentiating acquired versus inherited pattern based on the features in MRI, which is a supportive criteria. Now, when we talk about nerve biopsy, as we can see here, the A picture, if you can follow my arrow, sorry, the arrow is not coming, just a second. Arrow is not coming, I'll read it out. So the figure A, as we can see here, the star is for the perineural edema. In figure B, what we see is patchy myelin loss. So some of the nerve fibers are lacking myelinated layer. In C, we see the classical onion bulb appearance, which is evidence of ongoing renervation and denervation. And in the last two figures, we can see mononuclear cell infiltrate. So these are the patterns of nerve biopsy we see. Now, usually we don't go for biopsy. Biopsy is usually reserved when we don't feel that the case is of a classical CIDP, more for ruling out vasculitis, amyloidosis, or such atypical causes. The most important thing I would like to concentrate here is the nerve ultrasound. Since last few years, there are data in different publications coming up that now ultrasound role may be as good as of MRI as a supportive diagnostic criteria. What we usually see in now ultrasound is focal enlargement and mainly in proximal nerve segments. Now there are different scores given in different publications. Bocum ultrasound score has been referred by Sir's book also. The score is basically a point-based system which we use for different nerve entrapment at different sites, and then we divide it either as CIDP or MADSEM or MMN, and it can also differentiate between AIDP versus CIDP and other variants. The next slide we will concentrate more on the nerve ultrasound. So we'll like to concentrate first on the figure. As we can see here, A is the normal median nerve which has been taken by ultrasound at the middle of the forearm level. Now we can see the arrow, it points to the cross-sectional area. The dotted round arrows is the cross-sectional area of the median now in a normal patient, and the amount, as we can see here, it has been depicted as 7 millimeter per square, which is a normal find. B1 is the now ultrasound finding from a patient of a classical CIDP, and the arrow shows that there has been a significant enlargement in the cross-sectional area. And the more important thing to concentrate here is the echogenicity. In the first figure, we can see that there is normal echogenicity, and the second CIDP case, we can see there is hypoechogenicity. So two things we consider while doing ultrasound for a case of demyelinating neuropathy. First is cross-sectional area, which would be grossly enlarged, and the second is echogenicity. Hypoechogenicity favors acute demyelinating features, and hyperechogenicity favors fibroid remodeling and more of a secondary axonal degeneration kind of thing. Importance, as I have already told, the latest literature is coming up with the idea that now ultrasound may replace MR neurography with upcoming years. Advantage being it is faster and cheaper compared to the MRI findings. But the disadvantage that is that very proximal nerves or deep nerves, such as if we want to do the same findings for brachial plexus or lumbosacral plexus, it won't be very easy. And classical expertise is needed to differentiate all these minor things. So this was about now ultrasound as a newer diagnostic modality for CIDP. Now this has already been covered. Once more, a little bit of details about corneal confocal microscopy. How it has been emerging its role in CIDP is that the basic funda is that cornea being a transparent layer, we can see the subbasal plexus. This plexus is of the terminal branches of the ophthalmic division of trigeminal nerve, which supplies the corneal layers. And hence, in a normal patient, as we can see the figure A, there are classical normal myelinated nerve fiber layers. But in figure B, we can see the nerve fiber layers are very distorted, and we are not able to see the exact or enough number of vesicles in the affected patient in figure B, plus the inflammatory cell infiltrate also are there surrounding the nerve vesicles, which again favors an immune etiology of demyelination. So this has been also given in the newer literature as a coming up role for the diagnosis of CIDP and maybe supportive role. Now, once we confirm that it is a case of CIDP clinically plus electrophysiology plus CSF findings, that it looks more or less of a typical case of CIDP, we should rule out these secondary causes. Most of the things we usually practice in our day-to-day patient-based management, so I won't focus much. The only thing is that HbA1c, as Dr. Abhijit rightly said, CIDP has been associated as more frequent in diabetics, around 8 to 10 times more frequent in diabetics compared to non-diabetics. Hence, diabetes may be a contributory factor, so that should be kept in mind. And other causes, mainly this serum protein electrophoresis, immunofixation electrophoresis, and free light chains. This should be done to rule out monoclonal gammopathies, which can closely mimic a CIDP picture. Now, important here is that some of the patients may not be as affordable. In those cases, we should do serum protein electrophoresis along with free light chains, which, according to the latest literature, makes the yield of the outcome same as immunoelectrophoresis. So SPEP alone is not as sensitive and specific as IFE, but when we combine it with free light chain, the yield of getting the hello.
Yes,
Should I go on,
continue.
sir?
Yes,
Yes.
yes, please.
Yes. So then SPP plus free light chains almost give equivalent results to IFE. And when we are suspecting significantly in terms of monoclonal gammopathies, then serum VEGF level, which is almost a specific marker, will relate to the diagnosis of myelomas, and anti-MAG antibody is quite specific for DETs. I will come to that part later on. In case we are not finding any other secondary cause, PET-CT may be a relevant investigation to rule out malignancies and paraneoplastic syndromes. Now coming to the treatment aspect of a typical case of CIDP. First line options we all know, steroids, IVIG and plasma exchange. The efficacy has been quoted as around 50 to 70%. So what is important that despite being a classical case of CIDP, around 20% may not respond to the first line treatment. And this has two implications. First is to reconsider the diagnosis that it may be an atypical case or we are dealing with something else. Second, we should wait for a significant amount of period while switching to other treatments. Sometimes we see that a patient who has not deteriorated but not improved also, we tend to rush into the switching of the another treatment from steroids to IVIG or to the next level of treatment. But usually they say that at least 6 weeks period should be waited before switching, and sometimes the maximum benefit may be delayed till 12 weeks. So individualized approach in deciding about switching of treatment is necessary. Anything new in treatment? Yes, in recent years, around 2018, FDA has approved subcutaneous immunoglobulin. Efficacy wise, it is almost similar to IVIG. Then what are the advantages? It has very less systemic side effects and it can be self-administered. Dose is same, 20% what we use in IVIG, but it can be given as 0.2 to 0.4 gram per kg weekly. Now, last aspect is refractory CIDP. So this is a very gray zone in terms of definition, criterias, and the treatment for refractory CIDP also. There has been no clear-cut universal accepted guidelines for defining what we call refractory CIDP, how to approach it. But the important practical aspect what we can learn from this is rituximab, cyclophosphamide, bortezomib, and a number of other treatment options have been tried, but this has been based on some few small case series and all. Importantly, we should again reconsider the diagnosis before stamping it as a refractory CIDP, because many of the cases then later on after a re-evaluation turn out to be some of the other mimics. So this was all about a classical case of CIDP. As we have already discussed, 50% will not fall in this typical CIDP, which may be one of the listed CIDP variants, which includes mainly MEDSM, DETS, pure motor CIDP, pure sensory CIDP, and CISMP. So these are the typical CIDP variants. So going in a case-based manner, most of the case studies that I'm quoting now are based on Khadilkar sir's paper Beyond CIDP. So there was a 35-year-old female who came with right hand ring and little finger weakness since 1 year, slippage of footwear since 8 months, then developed weak grip in both the hands since last 4 months, not able to walk with worsening of balance in the dark since last 3 months, and tingling numbness in all 4 extremities with involvement of perioral region also since last 2 months. So to summarize, a very slowly progressive course over 1 year, predominantly distal weakness initially, involved multifocal different areas, and in the last few months has brought out in terms of large fiber as well as small fiber sensory involvement also. When we examine, as I have already told, distal weakness in both the hands, asymmetric proprioceptive loss in all extremities, there was areflexia and tremor in both the hands also. Interestingly, there was severe weakness and atrophy of tongue. Now conduction showed widespread multifocal demyelinating polyneuropathy with motor conduction block and chronic partial denervation of the tongue. So based on the findings, clinical electrophysiological finding, the diagnosis was made as multifocal acquired demyelination, sensory and motor, also known as Lewis-Sumner syndrome. It is more common in females. Now, most of the typical CIDP that we have seen earlier, it was stated that it is more common in males. This is one of the variety that has been labeled as more common in females. Again, starts around same age, 4th or 5th decade. Upper limb involvement is more common than lower limbs. Distal is more than proximal, and asymmetric sensory motor. So as Katrak sir also told initially, MMN with sensory involvement makes it MADSM, and the involvement would be more of a multifocal asymmetric sensory motor pattern. As we saw in the last case, there can be cranial nerve involvement. Now this is again very important. I'll come to the importance in the next few slides. We have seen already that the 12th nerve got involved in the last case. Now, two important points in terms of differentiating from other CIDP variants or mimics is that CSF protein is again very high, as same as of CIDP and pure sensory CIDP that we previously discussed. MedSum also has very high protein levels, sometimes more than hundreds. Unlike MMN, so multifocal motor neuropathy, one differentiation is that there won't be any sensory features. Another is CSF does not have as high protein levels as compared to MedSum. MedSum is a CIDP variant, whereas MMN will fall out of CIDP spectrum, which is a mimic. We'll see that part later on. Treatment, what we can give is steroids and IVIG. Again, I have kept as unlike MMN because MMN may deteriorate with steroids. We'll focus on those parts later. So this was about the first variant, MedSum. Going to the second variant, DADS. As the name itself suggests, it is distal acquired demyelinating sensory neuropathy. So from the name itself, it is quite obvious that most of the features will be limited to the distal parts. It is symmetric and predominantly sensory. Mild or minimal motor weakness can be there, but it is again limited to the distal aspects. Importantly, they can also have some tremors. IgM kappa monoclonal antibody would be positive. So this is a very interesting point that a typical CIDP variant has classical pattern of IgM monoclonal band, which we usually see in a CIDP mimic of monoclonal gammopathy. Anti-MAG antibody is positive in 50% of these patients. MAG is myelin associated glycoprotein. Now, based on positivity of MAG, we can divide DADS as two parts. DADS with MAG antibody and DADS without MAG antibody. This has two implications. One is that DAD with MAG antibody, they are classically defined as CIDP mimic and not a CIDP variant, whereas DADS without MAG antibody, so likely a idiopathic DADS, this has been labeled as a CIDP variant. More important is that the patients of DADS in whom we found MAG antibody, they are refractory to the standard treatments such as steroids, IVIG, and PLEX. They may respond to rituximab. Now, the underlying theory that has been given for this is that these are IgG4 class, same as what we found in nodopathies. And because of this, they may respond to rituximab. hence rituximab may be of useful, but they don't activate complement, and hence steroid, IVIG and PLEX are not of a significant benefit for these patients. But patients in whom MAG antibody is absent, they may respond to immunotherapy. So unlike CIDP, there would be disproportionate distal predominant motor and sensory involvement in terms of demyelinating finding of electrophysiology. Conduction block would not be present in a classical case of DETs. Sural response would be absent. So typical pattern of sural sparing will not be seen in DETs. And these are classically refractory to treatment, which should be knowing, and hence patient can be informed well in advance that the treatment response may not be as classical as what we see in a typical CIDP case. So moving to the third variant, again a case, 40-year-old male patient who presented with tingling numbness in left lower limb, followed after 1 month by right lower limb since 6 years. So long-standing distal dysesthesia. Now, initially, when the patient presented to us, before that, during the evaluation of this distal dysesthesia, patient was worked up for a routine classical garden variety of neuropathy, as Katrak sir already mentioned. So B12 was found to be low, and the patient was treated with B12 supplements, but there was no improvement. Weakness was not there until last 1 year. Now, since last 1 year, patient has complaints of severe imbalance and gait difficulty with worsening in the dark. So more of a progression in terms of sensory large fiber involvement. What we found on examination was a loss of joint position, sensation and vibration till ASIS, hence predominant large fiber involvement, with some loss of pain and temperature till both the ankles. So small fiber were also involved, but in a less predominant manner. Generalized areflexia, minimal lower limb distal weakness with normal upper limbs. Romberg was positive, again favoring sensory ataxias, and no cerebellar finding. To summarize, long-standing sensory involvement limited to the distal pattern, but B12 did not help the patient much. Then, since last 1 year, severe proprioceptive involvement, some mild distal predominant small fiber sensory as well as motor involvement. We went on for the nerve conduction, thinking in terms of snaps affected. What did we find is nerve conduction being normal. SSCP was grossly abnormal both in lower limb as well as upper limb, which was clinically normal. CSF was showing elevated protein with 10 cells. Rest of the workup, what we usually do in a case of predominant sensory ataxia, we did not find anything specific. We went for MRI spine, which showed lumbosacral root enlargement with enhancing fibers. So to cut short, predominant sensory ataxias with normal nerve conduction with abnormal SSCP, but mainly the diagnosis was based on CSF findings suggestive of immune demyelinating etiology plus MRI findings suggestive of root enlargement. This was the MRI. Neurography showed clinical classical lumbosacral lower segment root enlargement with thickness and contrast enhancement. So this was a case of chronic immune sensory polyneuropathy, where we classically find nerve conduction to be normal. So immune demyelination that are limited to the dorsal root, proximal to the dorsal root ganglia, and which is the reason nerve conduction turns out to be normal. Predominant sensory ataxia with areflexia. Investigation we already seen, nerve conduction will be normal with abnormal SSCP, and CSF and MRI will help in diagnosis these cases. Differential diagnosis would of course be ganglionopathy, but in those cases we will find SNAP to be affected, and the causes of ganglionopathy should also be ruled out, such as Sjogren and paraneoplastic. And these patients do respond to steroid as well as IVIG. So now going to the last two CIDP variants. We have already covered DETs, MedSum, CISP. The other two are sensory and motor CIDP. I have kept this as a tabulated form since most of the features are comparable. So first point says that both of them are quite a rare variety among the CIDP variants. When we talk about sensory CIDP, what we mean that clinically the patient will present with exclusive sensory findings, but there would be evidence of demyelinating features in motor nerve conduction also. Same for motor CIDP, classical motor presentation, but electrophysiology will show some evidence of sensory involvement in terms of demyelinating finding. Hence, clinically either sensory or motor, but electrophysiology will show predominant sensory or motor, but the other component will also be affected. Classical findings we already know. Important thing is sensory CIDP will respond to our classical first line options such as steroid, IVIG or PLEX. But again, motor CIDP will not respond, and some of those cases may even worsen on steroids. So we have two entities which does not respond to steroids: motor CIDP and multifocal motor neuropathy. Motor CIDP being CIDP variant and multifocal motor neuropathy is a CIDP mimic. We'll see that part later. So now we have seen that CISP, the case that we saw was a case of CISP who presented with sensory ataxia and areflexia. Whenever we see a patient with predominant large fiber sensory loss with some involvement of the small fiber as well as some motor weakness, the diagnosis seems to be critical as there are significant change in the treatment aspects. So when we talk about sensory ataxia with areflexia, the diagnosis can be either CISP, sensory CIDP, or even sensory neuronopathy or ganglionopathy. The diagnosis can be made based on electrophysiological difference. As we have already seen, CISP, nerve conductions would be normal with abnormal SSCP and supportive CSF and MRI findings. Sensory CIDP would have predominant sensory as well as some motor findings in nerve conduction, so we can differentiate them. And in sensory neuronopathy or ganglionopathy, there will be severe reduction in SNAP with normal CMEP. So only sensory part in the electrophysiology is affected. So this will help us in delineating the exact diagnosis as well as planning treatment. So this was all about CIDP variant. Now we come to the third part, which is CIDP mimic. So this does not fall into the category of CIDP, but the presentation somehow is very classical such as CIDP. Some are clinically and some are even electrophysiologically, and hence we should take some typical clues which will lead us to the mimic rather than typical CIDP pattern. So most of the mimics that we see are in clinical practice limited to AIDP or monoclonal gammopathy. So when we say AIDP, the differentiation is mainly difficult when we are facing either AIDP versus acute CIDP. So what are the points that will favor AIDP? Antecedent events such as vaccine or diarrhea or preceding signs of infection will lead to Guillain-Barré or AIDP type. Temporal progression and relapses we have already discussed. And autonomic respiratory and cranial nerve involvement again favors GBS rather than CIDP. Second entity is monoclonal gammopathy. I have one more slide to discuss this in detail, but the typical pattern when we should start suspecting that this may not be a classical case of CIDP is rather older age of onset. Usual CIDPs at garden variety will come around 40s or 50s. This will present around 60s or 70s. Another clue which we'll find later on after giving treatment is that they don't respond very classically as compared to the typical CIDP to the immune therapies. And the most important type of this monoclonal gammopathy that we should consider is POEMS. We'll discuss this more in detail. Other third variety is other chronic demyelinating neuropathy. Now CIDP is not the only chronic demyelinating neuropathy. There can be some other patterns also, such as multifocal motor neuropathy. And last is not to forget history, as some of the patients might be severely diabetic. As we already seen, Dr. Abhijit said that diabetic patients may have CIDP-like presentation. Other things are rheumatological disorders or other autoimmune disease in which the patient may have been taking drugs such as TNF-alpha inhibitors, infliximab, etanercept. Those patients may have drug-induced CIDP also. So focusing on some of the mimic types. This was one more case taken from Sir's article. A 62-year-old male patient. So the first clue comes here only. The age is not a very typical one. He presented with right hand weakness over a period of 4 months with some mild recent involvement of left hand also. No sensory symptoms. So pure motor distal asymmetric involvement over a period of 4 to 6 months. Based on these features only, the diagnosis comes as motor neuron. But as we know that we should not forget multifocal motor neuropathy. Keeping that in mind, we went on for nerve conduction. But there were no nerve conduction blocks. Only finding that were seen on nerve conduction was denervation and re-innervation of the distal hand muscles. We still went on to rule out multifocal motor neuropathy based on serological assessment. So anti-ganglioside antibody, anti-GM1 antibody was ordered. which again came out to be negative. So there was no evidence of electrophysiological finding or serological finding, which could have led us to the diagnosis of multifocal motor neuropathy pertaining to this case. And hence the patient was labeled as provisionally motor neuron disease and treated symptomatically. The patient came back after 2 years. Even after 2 years on follow-up, there was no progression. No bulbar involvement, no other limb involvement, no UMN signs, nothing else to suggest any significant progression in a labeled case of motor neuron disease. Now, considering the possibility of multifocal motor neuropathy without conduction block, a trial of IVIG was given and there was remarkable improvement. So this was not a case of motor neuron disease, but multifocal motor neuropathy without conduction block. Diagnosis becomes more difficult when we don't find the typical clues of multifocal motor neuropathy such as conduction block and serological evidence of anti-GM1 antibody. So coming to the first, CIDP mimic multifocal motor neuropathy. Now literature and also in continuum article it has been mentioned as actually a nodopathy, because the antibodies that are seen in multifocal motor neuropathy are targeting an entity which has been recently came into the literature as nodopathy or paranodopathy, which targets antigen at the node or paranodal level. So this anti-GM1 antibody is at the nodal level. Usually we find it in males around 4th to 6th decade, slowly progressive asymmetrical distal predominant motor weakness and no sensory involvement. Interestingly, 50% of these patients will also report fasciculation and muscle cramps and hence more diagnostic dilemma compared to MND. Again, cranial nerve may be involved. So we have seen two entities, MADSM and now multifocal motor neuropathy. Both can have cranial nerve involvement, and there are multiple reports showing hypoglossal nerve involvement. So as we discussed, anti-GM1 IgM antibody will be seen in around 40 to 60%. Importantly, almost half of the patients may not have this antibody. Another important thing is multifocal partial conduction block outside entrapment sites. Hence, we are ruling out compression neuropathy as one of the cause of conduction block. MRI is again important as it will support our diagnosis of MMN, in which we find enhancing brachial plexus. Now, one more important thing is IgM anti-GM1 antibody. It is seen in around 50% of cases of MMN. Neither specific nor sensitive, as IgG GM1 antibody is also present in MedSum, MND, and GBS. So IgM anti-GM1 antibody is to be ordered when we are suspecting multifocal motor neuropathy, and it should not be IgG type. Now coming to the treatment part, most of them do very well with IVIG. And when we talk in terms of monitoring the disease aspect with the treatment, one is of course clinically patient will improve as we saw in the last case, and other is antibody may remain, but the conduction block which we find at the time of diagnosis will disappear with proper treatment. And in some of the resistant cases where IVIG doesn't work, cyclophosphamide may be offered. As we have already stated, steroids may worsen this entity. So two entities where steroids are not to be given: multifocal motor neuropathy and pure motor CIDP. One more case, 44-year-old male presented with 3 weeks of generalized weakness and distal sensory loss. Examination showed power of around 4/5 in all major groups, but predominant large fiber involvement, again sensory ataxia with generalized areflexia. This time nerve conduction showed absent F wave, partial motor conduction block, and sural sparing pattern. So based on this first 3 lines, the progression is of 3 weeks. So still favoring acute, as Kathrak sir told, till 4 weeks it falls into the spectrum of acute, with demyelinating features, with gradually progressive course, with sensory more involved in terms of large fiber, and hence proving the pattern of demyelinating. The diagnosis was made initially as EIDP. Patient was treated with IVIG. There was no improvement. After 1 week, due to ongoing deterioration, patient was given a trial of plasmapheresis. Still, there was no improvement. Patient from mild weakness, as we discussed, of around 4/5, became quadriplegic, 0/5 power over a next 1 week. Now, at that time, they suspected based on the atypical course and not responding to the ideal first line treatment. So, this was the clue for evaluating the patient for some other rare varieties, and hence nodal and perinodal antibodies were ordered. NF155 came out to be positive. Considering the diagnosis of nodopathies and paranodopathies, patient was treated with rituximab and then he showed gradual improvement over few weeks with minor residual deficit. So coming to one more entity, nodopathy or paranodopathy, this is a relatively new entity, again falls in a CIDP mimic and not a variant. 10% of patients whom we label as CIDP may have nodopathies or paranodopathies. And as we discussed, multifocal motor neuropathy is also actually a nodopathy based on the site of involvement at the antibody level, which is a node. Now, if we can see the figure, the highlighted part A is taken from the node level, the B is from the paranodal, and C is the juxtaparanodal. So node of Ranvier, which is the unmyelinated area, then the paranode, slightly juxtaparanode is the third one. The red marks are the antigens that are classically being described in nodopathies or paranodopathies. In nodopathies, NF140 or 186 we see. In paranodopathies, Casper, contacting, and neurofacin 155 have been depicted as the causative antigen. Any other trick that we should be suspecting the previous case initially only as nodopathy? Yes. So as we saw in the last case, there was a very subacute onset of progression, almost 3 to 4 weeks. So going from acute to subacute, predominant sensory ataxia, tremor predominant features, and distal predominant involvement should have made an initial suspicion of nodopathy or paranodopathy. More important from treatment aspect is that they will not respond to the classical steroids or IVIG, and they may show good response to rituximab. So this was all about nodopathies and paranodopathies. Now coming to one more variant, paraproteinemic
Harsh,
neuropathy.
you have to be a little quick, huh? Harsh, we are
Yes.
beyond the time, huh?
Yes, sir. I'll complete it fast now. So paraproteinemic neuropathy, the clinical clues
Harsh, you should conclude
are
now.
elderly patients, severe autonomic involvement. Okay, sir. So MGUS and POEMS are the classical CIDP-like features. This was the last case study in which the finding was of Hodgkin lymphoma based on incidental finding of right inguinal swelling. So it is one more CIDP mimic. Rarely based on the classical other atypical features, we may find vasculitis or toxin or drug-induced neuropathy or sometimes hereditary neuropathy as the cause of differentials. And the last slide to conclude, this is the whole spectrum of CIDP. As we can see here, multifocal motor neuropathy, paranodopathies, and paraproteinemic neuropathies are outside the spectrum of a typical case of CIDP. And the new term that they include is chronic inflammatory neuropathies. These are the fine learning points. We have already discussed this. Thank you.
I have a few questions to ask.
Yes, sir.
Oh, Harsh.
Yes, sir.
Now, see, basically, you said chronic demyelinating neuropathy. Can you put up that slide, your friend?
Sir, first one?
No, what did you call it? Chronic immune
Yes.
demyelinating neuropathy, which is really not a, just keep going up, 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 fast, fast, go up, 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 up. Case, no? Up. Amongst the variants.
Variants, okay.
Now you call that, that is really not a diagnosis. Not this, not this. Before that, before that, before that. Okay. It is just a description of the neuropathy.
Yes,
it was chronic immune demyelinating neuropathy. I think
yes.
you must add one more word. You must add idiopathic if you have ruled out sovereign and paraneuropathy.
Yes, sir. Absolutely.
Okay. That is
Yes, sir.
one comment I would like to make. The
Yes, sir.
second comment that I like to make this terminology of acute CIDP oxymoron. If you take the full form of CIDP, how does it sound? Acute chronic inflammatory demyelinating polyneuropathy.
Yes, sir. Yes, sir.
How does that sound?
Yes,
So
sir.
please tell me the differences between acute CIDP, as you call it, and AI.
Sir, couldn't hear your voice, sir.
Sorry.
So your voice went.
Okay, sorry.
Huh.
You call it acute CIDP.
Yes, sir.
Now, what is acute chronic inflammatory demyelinating polyneuropathy? I think it is splitting hairs. You know?
Yes, sir. Yes, sir.
All right. That is my second point, because there's hardly any difference between AIDP and CIDP, apart
Yes, sir.
from the amount of sensory involvement. Where in AIDP, the sensory involvement is rather minimal, you
Minimum.
know,
Yes, sir.
whereas in
Yes, sir.
CIDP, you can get sensory ataxia as well.
Yes, sir.
Okay.
Yes,
And the
sir.
time course.
Time.
So I
Yes, sir.
believe that if you have an immune-mediated neuropathy in the earlier stages, the
Yes,
sensory
sir.
involvement is not much, but in the later stages, the sensory involvement is much more.
Yes, sir.
And the more becomes, you get my point.
Yes, sir. Yes, sir.
Yeah.
Therefore,
So one thing.
that's an evolution.
Yeah. So one thing, this acute, you're right. It's actually an acute onset of CIDP. That's the type of onset that we have. It's actually CIDP, but its onset is just like an AIDP, but it doesn't respond. It either, keeps going, down, 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 or it improves, but relapses again very fast. That's what they wanted to just make that distinction.
Yes, sir.
See, it is the autoimmune pathology which determines all that.
Yes.
And calling it a different variant of acute mutation of CIDP means CIDP is already there.
Correct.
Yes, sir.
So it's something like an acute relapse on a CIDP.
Yeah.
You get my point?
I
So
think they wanted more of an acute onset. Yes, sir.
I'm a little confused about this etiology. Okay.
Yes, sir.
So
Now,
can I
Yes,
another
just
remark.
okay. Yeah, Ji. Yeah.
Yeah, carry on, Jimmy.
Yes, sir. Please continue. Yeah, no, please continue, sir.
I'll tell you. The other remark that I would like to make is that very often physicians are treating diabetic neuropathies which are not responding to their diabetic control. When in effect, these patients have chronic inflammatory demyelinating polyneuropathy.
Quite right.
Yes. Yes, sir.
So please remember that
Quite right.
CIDP in a diabetic is not necessarily diabetic neuropathy.
Very true.
Yes. Yes, sir.
And I have treated,
very
I can say about 3 patients. I have treated diabetic patients with immunoglobulins, with plasma exchange, and one patient even with high doses of steroid with
steroids. Yes.
improvement in neuropathy.
Yes.
Okay.
Very true.
Exactly. Yes, sir.
In fact, in one such patient, I remember with high dose of steroid, the diabetes actually improved.
Okay. Now,
I mean,
the last remark that I would like to make is your MMN without conduction blocks.
Yes, sir.
The conduction blocks may be very proximal.
Yes, sir. That was one of the reasons. Yes, sir.
Yeah, therefore, reflect in your late spinal
Study.
responses.
Yes, sir.
Okay.
Right.
Yes, sir. Absolutely.
Perhaps in your H reflex. Okay.
Yes, sir.
Not in your F waves because it's pure motor.
Motor.
But
Yes,
if
sir.
perhaps in your H reflex, it may reflect a delay.
Hmm. Yes, sir.
So actually,
Great.
it is a limitation when you say MMN without conduction blocks. It's actually a limited biological study.
Yes, sir.
Right. It's an apparent this thing. Actually, if we look very proximally, we would get it.
Yeah,
Yes, sir.
but how proximal will you go with a conduction study? You can go up to the brachial
Right.
plexus, go up to a lumbosacral plexus. You can't go beyond that. And sometimes the blocks may be beyond that. And a manifestation of that will be that the CSF protein will be elevated.
Hmm. Yes, sir.
Right.
Okay. So these are some of the remarks that I would like to make on this. But I think people who work in this sort of field, they like to confuse the issue. And I don't quite agree with this acute CIDP. Normally they
Right.
Yes, sir.
confuse
Right.
the intensity, you know.
True. True.
Yes, sir.
Acute CIDP sounds so wrong.
Shiraz, will you
Yes.
please
I
share
wonder
your slide?
Asad is Asad, do you have any comments on that?
I think that the field is getting more and more confusing. That's what I would say.
Yes.
It used to
True. Very
it
true.
be simple according to the chronology. Now the chronology is simply remarkable. I don't really understand it. And the CIDPs, which coincide with diabetes, has been one very difficult area. And I have gone wrong on a couple of occasions when, like you, I thought it must be CIDP. But in neither of these two cases, which were offered plasmapheresis, it didn't help. And of course, both patients had diabetes and diabetic neuropathies also. That is a conundrum that I think we still have to face.
In those patients, I think if the diabetic neuropathy is present and suddenly the neuropathy starts deteriorating, that is
Yes.
a pointer something new is happening.
Obviously, yeah. On those grounds, it was suspected.
And if you already have a diabetic neuropathy, it is very difficult to establish a demyelinating neuropathy. So I think one has to just do a puncture, see whether the CSF protein is markedly elevated, and then give them a therapeutic trial.
Yeah, that's a good idea. Yeah, I think in only one of those the CSF was done, which was the CSF was not very high, but the other one didn't do it because there was not much time.
Fine. Yeah. Jimmy?
Okay. Thanks so much. Thank you. So shall we go, Ashok?
Yeah, please, Shiraz, please start. We are eagerly awaiting your talk. Yeah, you worked very hard. You worked very hard.
One
Yes,
question to Harsh, just
Yes,
before
sir.
we start with Harsh. Where did you get all these corneal photographs and whatnot?
Sir, there was a recent article, sir. I'll share with you, sir.
Kindly send it to me.
It's a nice
Yes, sir.
article.
Yeah, I saw it was some German authors, German guys who had sent that corneal photographs.
Okay, sir.
No,
I'll
actually,
send it.
Harsh took out one article, on the parallel to the continuum, which sort of helped to buttress some of the points of the continuum. So I think he'll share it with you all.
Unfortunately, because of time constraints, I didn't show the blood. You know,
So
I
your
didn't
voice
show
is
the
cracking
blood.
up. Your voice is cracking
I
up.
didn't show the blood. I did not show the blood investigations because
Ah,
of shortage
yeah,
of time.
time.
But
Yeah,
I have
yeah, yeah.
outlined all these things. I have
Okay.
outlined in demyelinating neuropathies, in painful neuropathies,
Oh, excellent.
and in Shakumari 2.
Hmm.
What are the limitations or what are investigations you should specifically ask for, like IgM, anti-MAG IgM in anti-GM1 IgM in MMN and the others, etc.
That
Okay.
can be excellent. 5 minutes we can spend next time doing that to finish it. We'd love that.
I want to go because I have a family obligation, so
Acha. Sure, sure.
I can do it some other time. You
Sure,
know.
sure, sure.
Okay.
Thanks so much.
Not. I would like to leave now. Thank you.
Thanks you.
Thank you
Thank
very
you
much,
very much.
everybody.
Thank you.
Righto. Bye.
Thank you.
Bye,
Bye.
Sarosh.
Right. Take care, sir. Enjoy it. Yeah. Let us welcome Shiraz. He has put up his slides and he's tested his mic. So here we go. Please welcome Dr. Shiraz Khan. He's from Hinduja Hospital, the second year DNB student. He has prepared this talk on Guillain-Barré syndrome from Continuum, and also a lot of contemporary points he has added to it. Come, Shiraz, please start. Please begin. Yeah, please begin. No sound, no sound. No sound, no sound. We're not getting any sound, my friend. Oh la la. Oh la 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 la. Yeah, yeah. Shiraz, I think we have to take a. We'll ask Arjun to start over and again test our mic. Again test our mic. Yeah. You'll have to stop sharing, please, Shiraz. I'm terribly disappointed. Arjun Shah, are you
Yes,
there? Yeah,
yes, sir.
please,
Yes, sir.
start. Please start sharing your screen.
Sure. Good afternoon, everyone. Are my slides visible?
Yes,
Hello.
yes. Yes, Arjun.
Yes. Good afternoon, everyone. So today we'll be discussing the management of neuropathic pain with a special focus on diabetic neuropathy. So just to define neuropathic pain, it is simply pain caused by any lesion or disease of the somatosensory system. So this is a great problem which doesn't get enough attention. The prevalence of polyneuropathy is expected to be about 4% in the general population. And out of these 20%, that is 1 of 5 have a painful neuropathy. And when we consider India is the diabetes capital of the world, and the amount of patients in India that have diabetes, similar to what they found in Western countries, the prevalence of painful neuropathy and diabetes about 25 to 30%. This is actually a little higher than the global average. Access to some of the epidemiological characters of diabetic neuropathy. Again, the prevalence is about 20 to 30%, and most studies show that males are either equally afflicted as much as females, or sometimes more so. And it's important to recognize that other features such as the age of the patient, other comorbidities such as renal disease, dyslipidemia, metabolic syndrome also play an important role in this. So the common etiologies, again, for pain has an underlying cancer, then chemotherapy is also an important etiology. There are certain other drugs, especially in our country, like isoniazid, and every week we see tens of patients who have a painful neuropathy because of linezolid. Alcohol-related neuropathies also can be, we must recognize that even excess, especially of pyridostigmine, can cause a painful neuropathy. Retroviral disease is again another cause. Amyloidosis, plasma cell dyscrasias, autoimmune diseases such as Sjogren's syndrome, the hereditary sensory and autonomic neuropathies, heavy metal poisoning, especially patients taking some sort of Ayurvedic therapy that isn't given in proper packaging. And if all of these are negative, even idiopathic painful. The pathogenesis is quite complex and poorly understood, but a few salient features are that it begins with the beta and delta fibers. These get damaged and the component and reduce inhibitory component from the central nervous system as well. And there is an upregulation, and the NAV 1.7 channel, in fact, is what causes painful familial erythromelalgia. And most of the medicines that we use for painful neuropathy, management of painful neuropathy can be broadly classified into 3 categories: pharmacological, nutraceutical, and non-pharmacological. So start underlying condition, and since diabetes is by far the most common cause of a painful neuropathy, it's extremely essential to understand that glycemic control is by far the best treatment. Other pharmacological treatment is scarce. In fact, in the past decade, an armamentarium. Treatment of painful neuropathy is quite challenging and quite frustrating at times. What we must remember is we must and then consider adding new therapies. So remember to combine various medications. Negative symptoms will not respond to treatment, and the patient should be explained the same in the beginning itself. Another thing is these are purely symptomatic therapies. we should set realistic targets because often the patient is very agitated. Diabetics will be taking is metformin. Metformin causes B12 deficiency, which can occasionally cause a broad subcategories of medicines, the gabapentinoids, the tricyclic antidepressants, and the serotonin norepinephrine reuptake inhibitors. Second line, we have the anti-epileptics, mexiletine, topical agents like lidocaine and covered and used and explored for its role in epilepsy to delta subunit of voltage gated calcium channels in the dorsal root ganglia and hence have an analgesic effect in neuropathies. So the first of these agents is gabapentin, and gabapentin has a level B recommendation by the American neurology. American go up till 3,600 milligrams a day. And this needs to be adjusted as per the creatinine clearance. A lot of this is something we must take care of. And common side effects are sedation, edema, weight gain, and even some cognitive changes and encephalopathy. The important thing to learn in this is that we can give a fairly higher dose of gabapentin. Very often we give a much smaller dose than that is recommended, and we feel that the drug isn't working. So we can go up to 3.6 grams a day. Clearance. An interesting thing is, even though pregabalin and gabapentin have a very similar mechanism of action, there are preclude response to the other. Side effects are again similar, sedation and weight gain. Then we have the tricyclic antidepressants, again serotonin norepinephrine reuptake inhibitor, which we'll see later. That's its primary mode of explains its side effects. So the common agents we use are amitriptyline and nortriptyline. And we can start them at about 10 to 25 milligrams. It's advisable to give them at bedtime because they often cause sedation, and we can slowly increase by about 25 milligrams a day every week. And especially in diabetics who anyway have a lot of cardiovascular risks, this is something we need to monitor. Side effects commonly sedation. If this patient has diabetic neuropathy with avoided because of its anticholinergic side effects, because it can lead to. Then we have the new, as the name suggests, increasing serotonin and norepinephrine. What happens is they increase the dorsal horn and the dorsal root ganglia. So the commonly used agent in this is duloxetine, again given a level B recommendation. The dosing is 60 milligrams once a day. We can go up till 120 milligrams. So this also acts as an antidepressant, and it's a fibromyalgia. So if we have a patient with neuropathy and who also has features of fibromyalgia, that is non-specific aches and pain, some depression, and there is a theoretical risk of it causing a serotonin syndrome. So again, the other medicines that the patient is taking must be reviewed. Another example is we can start at 37.5 milligrams a day. Maximum dose is 225 milligrams. Side effects are again syndrome. However, if the patient does acquire some of these adverse reactions, we must remember to start with the anti-epileptics. The anti-epileptics are theoretically used for neuropathic pain. However, evidence valproic acid, oxcarbamazepine, and topiramate all can be used. They all are very modestly effective, but they come with their own side effects. Carbamazepine was not shown to be better than a placebo, and neither was lamotrigine. So if we must use anti-epileptics, the option studies indicate that it's not. Newly approved drugs are topical lidocaine and topical capsaicin. Lidocaine, as we know, is a local anesthetic. Since these are topical medications, they have minimal side effects. They are available as ointmentation. It acts at this TRPV1 channel, and it's an epidermal axonal degeneration. So those nerve endings that we spoke about, it basically degenerates them, and hence the very caspacin is basically a spice that we often use in cooking, and we can even get from capsicums and bell. We are to apply it or teaching a patient how to apply it. Whoever is applying this medicine to the patient should wear gloves while applying it and make sure they don't scratch their eyes. So usually it's not very even patches, and we can apply 3 to 4 patches at various parts, and each patch lasts up to 3 months. And since it's a counter irritant and burns a lot, we can first apply lidocaine and then apply caspacin for the patient. So there's 2 drugs, and they might help. So these should be kept for severe and refractory cases when all else fails. And the most common drug agonist and also a serotonin norepinephrine reuptake inhibitor. We can start at 25 milligrams 6. However, there are a lot of issues with keep increasing the dose, and we all know the side effects of opioids. Another thing is there is sensitization of these new receptors. So after a while, the opiates can paradoxically cause hyperalgesia. This is called opioid-induced hyperalgesia. So this would be very counterproductive. And they are very addictive, and they have an addictive potential. So a lot of patients can get it. It's best to refer them to a pain clinic. A few common medicines are in this. So the one mentioned in continuum is alpha lipoic acid. It's basically an antioxidant. So there are a few studies, neuropathic pain scales. However, they're not very, very effective, and they can cause. Hello, can you hear me?
Yes, yes.
Shall I continue?
Yeah. Yes.
Then we have
Yeah, please continue. Please continue.
we have the non-pharmacological agents then. So this is one thing that is stressed upon a lot now, that is exercise. And it's hypothesized that this increases neurotropic growth factors at the dorsal root ganglion. And another important thing is it reduces the comorbidities that add to the neuropathic pain, like obesity, keep maintain glycemic control, helps treat underlying conditions like metabolic. Is moderate aerobic exercises about 4 hours a week. That comes up to about 45 walking. Even other exercise modalities like yoga, whatever the it's a simple and cheap solution. When this is surgically place electrodes in the epidural space and electrically stimulate nerves of the dorsal columns to inhibit them. This, however, only provides short-term benefit. Cannot undergo MRIs, which is quite disabling to neurologists as well. Acupuncture is used, but meta-analysis suggests that there is no role for this. So an approach which is recommended here is we could start with the first line agent or GABA. Gabapentinoid or an SNRI for 6 weeks and the maximal tolerance. Add another first line therapy while at the same time advising the patient to exercise. And if none of them works, we could add another second line agent or refer to a multidisciplinary plain clinic, or once again reassess for any patient education is of paramount importance. Thank you.
Okay, I have learned nothing else.
There should be, because you're not muted.
Vinaya, do you want to make any comments?
No, sir, it was very well presented by Arjun. He's discussed the treatment. So, if anyone has any questions.
Yeah, I think it's a pretty composite talk. And apart from the medication, what I found interesting was he's also had to discuss many non-drug related intervention that's becoming more and more common. I too suspect our patients are slightly more able to tolerate pain than the average Westerner, because the doses that they are prescribed in the Western books are not commonly used by us. We don't go up to 3,600 milligram of gabapentin almost ever. I don't have a single patient who's going to 3,600 milligrams of gabapentin. So I think most of our patients go 900, 1200, maximum 1500. But the doses recommendations you read from the Western books, fine. You got to read them. But then you don't prescribe the same thing in your own patients. So be careful about that when you go into your practice. So
I agree with that. I think that patients actually are very sensitive to some drugs, particularly I find pregabalin, and there are a lot of dropouts with pregabalin. And we should start low and slow. And that is probably better for our patients than these. And the absolute amount of drug should be much less, as Ashok was saying, than the Western textbooks state. I don't think our patients really tolerate this. And there are a lot of dropouts.
They don't demand it also. They don't come and say that, please give me something more, increase the dose. They don't demand it. As a Westerner, if you talk to our colleagues who are practicing the West, they sometimes have a rough time in the OPD. That they go on asking more and more medications in the OPD. They have a little bit of problem managing those patients. Yeah. So Arjun, as expected, your talk is absolutely complete and composite.
Yes, it was a very good talk by Dr. Arjun, and nicely illustrated also.
I've had good interaction with him on this forum. So, yeah. So Azad.
Yes, sir.
Can we start MND? After we finish MND, we'll ask Shiraz to come again. To finish your anterior onset disease.
Yes,
and then we'll
sure,
ask
sir.
Shiraz to come in.
Yeah. Sure. Varun, take over,
Yes, sir.
please.
Yeah, Varun is going to talk about it. Yeah.
Yes. Good afternoon, everybody. Sir, is my screen visible, sir?
Yes. Yes. Very well.
Yeah. I'll be talking today on motor neuron disease under the guidance of Azad, sir. Introduction. Motor neuron diseases include a variety of acquired and inherited neurodegenerative conditions that entirely or predominantly injure motor neurons. ALS is the most commonest of these diseases, incidence being 2 to 3 per lakh. If the involvement of motor cortex area 3-5, it predominantly causes UMN features. If there is involvement of motor nuclei of the spinal cord, that is the anterior onset, the features will be predominantly of LMN. If the motor nuclei in the brainstem is affected, bulbar ALS, and the mixture of all this is anterior amyotrophic lateral sclerosis. Coming to variants of MND, ALS, the limb onset being a majority, that is 2/3 of the patients, a bulbar onset of 1/4, where the bulbar onset it's 20 to 25%. PMA and PLS onset is of 5%. Respiratory onset is 3%, and FTT in 1 to 2%. The onset of these may be upper motor neuron only or lower motor neuron only or a combination of these. So on examination, the findings which we see predominantly of upper neuron UMN signs are, as we all know, increased tone, hyperreflexia, extensor plantar responses, spastic gait, and exaggerated jaw reflex. Element being muscle wasting, weakness, fasciculation, absent or reduced deep tendon reflexes. What we have to remember also is UMN is also, yawning is also UMN sign. On further examination, asymmetric wasting, which is distal predominant, much more than proximal. Weakness, distal more than proximal. Fasciculation seen in the proximal large muscle groups and along the lateral borders of the tongue, which is best observed without protrusion. Along with that, a head drop with weakness of the neck extensors are seen. Other differentials which has to be considered are myasthenia, myopathy, and MSA with head drop. We have to consider these three differentials as well. One more important clinical clue is a retained reflex in a weak limb. Motor neuron disease should always be considered as one of a differential. The split hand phenomenon, where there is preferential wasting of the lateral aspect of the hand, which is seen in the figure, with first dorsal interosseous and the APB muscle wasting, which is quite specific for ALS. And clinically, it manifests with the loss of the pincer grasp. This is an image showing ALS presenting as man in barrel. So coming to second variant, bulbar ALS variant, which is seen in 1/4 of the patients. This is the MND where elderly women are more affected than the men, unlike other ALS variants. It's a rapidly progressive dysarthria with prominent emotionality present. Limb functions are preserved for months and diagnosis by EMG of the tongue. They usually respond better to riluzole. And if the patient presents with bulbar symptoms with eye signs, myasthenia and oculopharyngeal muscular dystrophy differentials has to be considered. PMA, that's a progressive muscular atrophy. It's a pure element type where it compromises of 5 to 10% of MNDs, mostly are sporadic, with younger onset and male to female ratio being 4:1. Usually the progression is of 12 to 15 years, unlike other MND where the progression is of 3 to 5 years. And onset is often symmetrical, similarly a distal more than proximal. And respiratory system involvement is usually a late manifestation. Reflexes are absent to sluggish and cramps are fasciculations as well. Coming to the next variant, that is primary lateral sclerosis, where it is the rarest, where the incidence being less than 5% of the total anterior, that is total motor neuron disease cases. Only cells of motor cortex gets affected. To tell it has a primary lateral sclerosis, there must not have any clinical or electromyographic evidence of LMN for 4 years duration. And atrophy is a very late feature. Survival is longer usually of 15 to 20 years. So PLS being predominantly human, there should be absence of marked fasciculations of muscle atrophy. There should be no sensory bowel and bladder signs. There should be no family history, and imaging for compressive etiology has to be ruled out. But 77% of the patients go on to develop to ALS, where the survival is reduced from 12 to 15 years. This is showing hypertensive corticospinal tracts. On the left side we have, and on the right we have T2 coronal, where the wine glass or a garland sign shown by the arrow mark is seen. Coming to the next variant, that is hemiparesis, Mills syndrome of PLS variant. It's a very rare, slowly progressive spastic hemiparesis with generalized hyperreflexia and no sensory involvement. Standard MRI is normal. So a PET scan demonstrates microglial activation in the contralateral motor cortex, and the condition is considered to be a variant of primary lateral sclerosis. This slide shows the motor neuron disease with cranial nerve involvement. Here we have sensory neural deafness. If there is no sensory neural deafness and there is presence of UMN and LMN and the onset is adulthood, so the most probable diagnosis would be amyotrophic lateral sclerosis. Or if the same with with the age of onset being childhood with no sensory neural hearing loss with UMN and LMN signs, so the most likely diagnosis would be facial Londe syndrome. And if there is a sensory neural hearing loss with the presence of lower cranial nerves and with the presence of LMN signs only and a family history, then brown-violet Van Leeuwen syndrome has to be considered. With no family history, a Madras motor neuron variant has to be thought of. So next is MND with sensory involvement. Either it can be spinobulbomuscular atrophy, that is Kennedy's disease, or a paraneoplastic disease. Coming to spinobulbomuscular and with Kennedy's disease, it's an X-linked disorder, manifests only in male. CAG trinucleotide repeat, exon 1 of androgen receptor gene is the positive gene. Symptoms are usually present in the 4th or 5th decade of life. It's a very slowly progressive element syndrome with muscle cramps and initial weakness and wasting in the legs or bulbar region. Most important is fasciculations are common and present over the chin, that is the face, and tongue furrowing is the characteristic. Reflexes are absent or reduced. Clinically, sensory loss with sensory neuronopathy is a feature. Confirmation is by genetic testing. 40 to 62 CAG repeats are seen. Respiratory failure, like other MNDs, is the most common cause of death. There may also be a sign of androgen insensitivity with gynecomastia and reduced fertility. This is the image showing furrowed tongue and gynecomastia in a spinobulbomuscular atrophy affected patient. Coming to the next variant, paraneoplastic MND. This is a very rare disorder. Like motor neuron disease, aggressive progression and associated weight loss is present. May present as ALS, PLS, or PMA variant, or as a part of larger paraneoplastic disorder. Sensory plus motor, both features are present. And LP in suspected paraneoplastic disorder should include testing for oligoclonal bands as well. So the common neoplasms associated with the presentations of paraneoplastic: ALS presentation with breast, uterine, ovarian, lung and renal carcinoma, PLS with breast and lymphoma, PMA with Hodgkin's and NHL. So when to suspect paraneoplastic ALS? When the signs of ataxia, sensory loss, or dysautonomia are present. MND with extrapyramidal involvement. So the ALS Parkinsonian dementia complex of GOM represents the extreme examples of the phenotype overlap of Parkinson's disease and ALS. It has been long recognized that more typical cases of MND often have overlap with Parkinsonism. Such features often occur late rather than at presentation. PLS with bulbar dysfunction plus postural instability may simulate PSP. However, eye movement abnormalities are a clue. The two FDA-approved drugs, that is riluzole and edaravone, we have, that is, however, the benefit of overall survival is only up to 2 to 3 months, max up to 6 months. Where edaravone, we administer a 60 mg IV infusion over 1 hour for a period of 14 days, followed by a 14 drug-free period. Other symptomatic management described by the author in this continuum article is for bulbar segment of dysarthria, dysphagia, cough, sialorrhea, laryngospasm, and other cognitive related issue with cognitive impairment, where we give a low dose SSRI, low dose trazodone, or a low dose atypical antipsychotics like olanzapine, quetiapine, or arpiprazole can be used. Other treatments which are in investigation: mega dose of vitamin B12, where a 25 mg per day of high dose, ultra high dose of methylcobalamin were used, and there was a significant improvement in quality of life. However, the sample size was low in these investigational treatments. Other treatment strategies like masitinib, it's a oral tyrosine kinase inhibitor, and we have tofersen, it's an antisense oligonucleotide, and ravulizumab, it is a humanized monoclonal antibody that blocks the terminal complement C5 activation, where in all these investigational treatments, there is improved quality of life according to the functional score. We have other treatment of mesenchymal stem cell bone marrow derived transplantation, where there was a significant improvement in the ELS functional residual score. That is, it improved the quality of life. Now let's quickly go through 4 cases, where in case 1, we have a 22-year-old final year MBBS student complaints of clear-cut fasciculations of the right upper arm since 10 days. Both the thigh and calf fasciculations were seen since many years. He was extremely frightened and he accompanied with a cup of coffee. Examination was normal. Yes, this is benign fasciculations, which is commonly seen. anxious medical student or in a qualified clinician or in other individuals typically under 40 years of age. It's a part of normal physiology. Exercise, anxiety, caffeine, and other alcoholic beverages may all provoke fasciculations. Approximately 10% of thyrotoxic patients display them floridly. In the absence of weakness or abnormalities of thyroid function or electrolytes, individual age less than 40 years can be reassured without resorting to the electromyography to avoid the small but highly damaging possibility of false positivity. A clue is, as already discussed, fasciculations in youth. These are some interesting question. How much time must elapse after inserting the needle EMG to call a muscle fasciculation free? Among paraspinals, which is more specific, can we differentiate benign from malignant fasciculations from EMG? Methods to bring out fasciculations. So 90 seconds has to pass to tell the muscle is fasciculation free. Needle has to be inserted and has to be waited for 90 seconds. And which is the most specific? Yes, mid thoracic is more specific from lower thoracic, as the cervical spondylosis is more in spondylosis is more in lower cervical and lower thoraco-lumbar segment. Can we differentiate benign and malignant fasciculations? Electrophysiologically, no, but yes, by the accompanying like wasting, weakness, clinically, yes. So what are the methods? Adequate inspection has to be done. Palpation for fine episodic ripples in obese patients. Percussion by tapping. Again, it's a query. It's not a textbook description method. Auscultation by keeping a steth over the suspected fasciculation muscle. Other methods like sprinkling ether, excising the limb, pursuing of the lips, and the drug pyridostigmine. Sonography and placement of electrodes of the EEG and of course EMG MCS are the other methods to bring out fasciculations. So coming to case 2, here we have a 20-year-old right-handed architecture student painting as hobby, has given it up since past 6 to 7 months, as he had issue of slowly progressive atrophic weakness of the right upper limb. Neurologic examination showed weak and wasted right arm, forearm, and the hand, but no UMN signs. Sensory was within normal limits. There was no fasciculation observed during the entire examination. So here we have this MRI where we can see a cord atrophy and there is posterior dura collection. So cervical MRI showing asymmetric cord atrophy on neck flexion, anterior shifting of the posterior wall of the lower cervical dura sac, resulting in cord compression. Yes, this is Hirayama's disease, brachial monomelic amyotrophy, cervical flexion myopathy, where it's a pure motor focal amyotrophy of C7 to T1 spinal segments, almost exclusively in young Asian men of age 16 to 25 years. Usually, unilaterality is the most striking feature. However, 10% can show bilateral also. The most common explanation is the posterior dura is short and overstretching during flexion causes compression of the spine, leading to dynamic injury to the cervical spine and the damage to the anterior horn cells. So oblique amyotrophy, where the wasting and weakness characteristically involves muscles innervated by the C7 to T1. Thus, the shoulder girdle is usually spared, and there is often a striking sparing of brachioradialis in the forearm, giving rise to this. Fasciculation appear to be rare. And the weakness and the wasting, patients may describe worsening of these symptoms in cold weather conditions. And a large set of patients, there is increased allergic predispositions. The MRI image showing the snake eye appearance, which can be seen in ALS as well. Coming to case 3, here we have a 52-year-old male, right-handed desk job, presented with complaints of neck pain and lower backache since 2 years, loss of dexterity with right upper limb since 1 year, and imbalance on walking since 6 months. There was no sensory, cranial nerve, or bowel and bladder. On examination, wasting of small intrinsic muscles of both the hand, bilateral, supinator, biceps, and triceps fibers. Power was 4/5 proximally in the right upper limb, and weak hand. Left upper limb power was within normal limit. The right plantar was extensor, and SSCP was within normal limit. He had underwent C5, C6, C6, C7 decompression 2 years back. This was his MRI, where we can see multi-level compressive etiology. 9 months later, he presented with progressive weakness of both the upper limb, weakness of both the lower limb, right more than left, with speech progressively worsened 4 months. On examination, there was wasted limbs with retained reflexes, spastic speech, and bilateral plantars were extensive. This is MRI, which showed no much significant or no much degenerative changes. So yes, this was anterior horn cell disease, where the initial clues were right plantar being extensor, and in spite of multi-level compression degenerative changes, SSCP was normal. So electrophysiological test would have helped us to diagnose at the initial stage. Fourth case, a 32-year-old male with progressive loss of hand dexterity, which limits his activities of daily living, of breaking chapati, inability to button, unbutton, typing and writing since 6 months, where there was no significant thinning and no sensory deficit. On examination, his right supinator and biceps were absent. Triceps was sluggish. Next, electrodiagnostic testing demonstrated motor conduction block in the ulnar nerve and slowing of the median and ulnar motor nerves with normal sensory responses. GM1 antibodies were positive, and the patient was diagnosed with multifocal motor neuropathy. Strength improved after the initial course of IVIG, but over the next 1 year, slow decline and repeat IVIG might be required. Consideration for long-term immunosuppressant is also required in few patients. A small note on multifocal motor neuropathy with conduction block. It is 10 times rarer than motor neuron disease. It's a pure motor neuropathy, slowly progressive, asymmetric, and distal weakness. Wrist or finger drop are common initial symptoms, but 1/3 cases presents in the lower limb. Reflexes are lost, but can be retained in up to 20% of the cases. Respiratory involvement is rare. Demonstration of conduction block at non-entrapment sites is diagnostic. Differences between MMNCB and MND. A younger age of onset, that is for less than 40 years, favors more of MMNCB. 60 years in case of MND. Weakness is much more than wasting. In motor neuron disease, there is wasting is slightly more or equal to weakness. Reflexes are usually lost in MMNCB. Retained reflexes in a wasted weak limb, always diagnosis of MND has to be thought of. Bulbar involvement is never in MMNCB. Bulbar involvement can be there in MND. Anti-GM1 ganglionocyte antibody are present in MMNCB in 50% of the patients. Conduction blocks are seen in electrophysiologically. However, in MND, electrophysiological helps in diagnosis. And the IVIG is the treatment in MMNCB, whereas in MND, only supportive therapy is. A small note on weakness-wasting relation in neurology. If the weakness is much more than wasting, it's myopathic. Weakness is equals to wasting, it is neurogenic. Or if the wasting is much more than weakness, then a non-neurogenic like diffuse atrophy has to be thought. A small note on post-polio syndrome, progressive post-poliomyelitis muscular atrophy, seen in 28 to 64% of polio survivors after a stable course of at least 10 years develop. Progressive limb weakness with or without atrophy in previously affected and at times unaffected muscles. Fatigue, pain, sleep disturbance, cold intolerance, depression, dysphagia, dysarthria are the usual symptoms, which has to persist for a year. And electrophysiologically, giant motor unit potentials indicate chronic denervation and renervation. So a muscle biopsy usually reveals acute and chronic neurogenic atrophy with marked group fiber atrophy and fiber type grouping. Treatment, whether debatable, doubtful of IVIG is still independent, and other management of the depression and symptomatic treatment is given. A few slides on ALS mimics to summarize. ALS mimics with predominant LMN type weakness. A diagnosis to be thought of benign physical lesions, inclusion body myopathy, multifocal motor neuropathy with conduction block, neurologic amyotrophy, monomelic amyotrophy, muscular atrophy or Kennedy's disease, motor predominant Charcot-Marie tooth or distal SMA, post-severe denervation like post-polio syndrome. ALS mimickers, which are predominantly of upper motor predominant. Diagnosis to other diagnoses to be thought of are nutritional myeloneuropathies like vitamin B12, copper deficiency, hereditary spastic paraparesis, adrenomyeloneuropathy, late onset Tate's disease, polyglucosome body disease, HIV myelopathy, multiple sclerosis, and cervical radiculomyelopathy. So to conclude, motor neuron diseases, particularly ALS, remain devastating disorder without substantial disease-modifying treatments. ALS diagnosis remain clinically based on upper motor neuron and lower motor neuron symptoms and signs. Gene discovery in familial ALS has expanded our understanding of the affected pathway, resulting in cellular degeneration. Thank you all.
Yes, Varun, this was a very well done job. What was the most fantastic part about your talk is your slide on how do you approach ALS? How do you approach ALS with cranial nerve involvement? What is Faziolonde? What is Madras type of motor neuron disease? What that flow chart that you made is absolutely fantastic. Absolutely fantastic. And I think each one of the students should have it with them when they have access to this. Azad, do you want to say something? Azad?
Just very well done. Very well done, sir. He's spoken very well and nicely paced talk. He covered so much, but he didn't really go fast. He still covered it so well. Perfect.
That chart will stay with you and you will need to use it for the rest of your life. I promise you that. I promise all the students that this chart, you have to know it by heart for the rest of your life. In your OPD, in your clinics, what have you. It's absolutely amazing. Yeah. So anyone else wants to say something? Dr. Khan, sir?
No, I think he's covered it extremely well. It was a very good presentation. Thank you.
Yeah. So I think we are going to allow Shiraz to have one more go. Varun, would you please stop sharing? Yeah, Shiraz, will you please start sharing?
Am I audible, sir?
Yourself. I can hear you. I can
Oh,
hear you.
I'm so sorry. I'm so sorry, everybody, for the
God bless you.
technical glitch.
Come on, Shiraz. Come.
I'll
We are
just
all
quickly.
waiting for you. Eager.
Yeah. I'll just quickly share the slides.
That's news. Great. Please start sharing.
Yes, sir. One second.
Yeah.
Okay. Are my slides visible?
Very visible. Very visible. Please start.
Okay. So my topic is Guillain-Barré syndrome, and my mentor is Dr. Ashok Sesar. Obviously, he doesn't require any introduction. I'll just move on for the introduction. GBS is basically a heterogeneous group of peripheral nerve disorder in which the presentation is usually acute and is usually post-infectious with paralytic presentation and has an autoimmune base. What are the types of GBS? We have demyelinating, in which we have PID axonal variant, in which we have an amniotic variant, and a special type of Miller syndrome, which is a triad of ophthalmoplegia, ataxia, areflexia, and few people consider Bickerstaff encephalopathy to be on the spectrum of GBS, and hence it has been included as a type of GBS. Okay, the course of GBS is quite diverse, and the presenting complaint can be various depending upon motor, sensory, autonomic involvement. And the course is mostly monophasic in 95% of the cases. In 2/3 of the patient, if you take a history, you'll find antecedent respiratory or diarrheal illness in 4 to 6 weeks before the onset of symptoms. And nadir is rich in next 4 weeks, followed by a highly variable static period, followed by a recovery in majority of the patients in 6 to 12 months, with some having residual deficits. What are the risks which increases the mortality? Advanced age, severity of the disease, mechanical ventilation, pulmonary and cardiac complication, as well as systemic infections. Okay, how do you diagnose? GBS diagnosis is mainly clinical because we cannot waste time on investigation, as this is an emergency and required to give a treatment as early as possible. This is a chart suggesting what are the requirements, and the main two things which is required for diagnosis of GBS is progressive muscle weakness of more than one limb, along with areflexia and hyporeflexia. Okay. Next is, what is the role of NCV or EMG in GBS patient? Not much role has been found in early course of the disease, though the early changes which we found are prolonged F wave latencies, or you can say absent F waves, and sural sensory amplitudes are spared compared to upper limb. And NCV basically supports the diagnosis by confirming the peripheral spinal roots and or nerves involvement, with, and also differentiates between the two subtypes of axonal and demyelinating. It also helps in prognostication of the GBS. What is the role of lumbar puncture? CSF characteristically shows normal cell count and high protein levels, which we have termed as albuminocytological dissociation. It is usually seen after first week of disease, and it is mainly done to exclude the other causes for paralysis or GBS mimics, which we will be discussing in the further slides. Okay, what is the role of serology? Basically, antibodies, anti-gangliosides, not much, the role is not much well established in AIDP, but can support the diagnosis of minor variants of GBS, like Miller-Fisher variant, which has 95% of the patients have GQ1B antibodies. This slide basically is to discuss GBS disability scale. It is to be applied when the patient comes to the emergency. It has 6 grading. 0 is a healthy person. 1 is a person who can work, do manual work and run. 2 is a person who is able to walk 10 meters without support of stick or cane, but is not capable of manual work or running. 3rd is able to walk 10 meters with the help of cane. 4th is confined to bed. 5th is requiring ventilatory support, and 6th dead. So this is grading of the disability due to GBS. Next, we move to prognosis. What are the poor prognostic factors? Age older than 40, past history of diarrhea, short interval from onset to nadir of the disease, need for mechanical ventilation, high grade deficits on the GBS disability scale, which we just saw, and persistently low compound motor action potential amplitudes. Okay, next 2 slides are very important. We have 2 scales which we use in GBS patient. One is Erasmus GBS Respiratory Insufficiency Score, also called IGRIS. It basically allows to predict how many patients will need a mechanical ventilation during their first week after the admission. And the next slide is for that. Basically, it is calculation from 3 things. One is MRC sum score. It is basically power charting from all 4 limbs. And second point is days between the weakness onset and the hospital admission, facial or bulbar weakness. Accordingly, we chart the IGRIS score, and if the score is between 0 to 1, the patient comes in a low risk group. That is, only 4% of the patient in low risk group will require mechanical ventilation. 3 to 4 is an intermediate risk group in which 24% of the patients will require mechanical ventilation, and high risk 5 to 7 score, 65% of those patients will definitely require a mechanical ventilation, and hence we can take a decision of shifting the patient to ICU directly. Okay, next scale is modified Erasmus GBS outcome score, which is MEGOS. Basically, it predicts long-term functional outcome and tells us about probability of patient walking independently at 1, 3, and 6 months after the disease onset. Here is the chart. It is applied 2 times, one at the admission, one at after 1 week of the admission, and basically it also has 3 components. Age of onset, we give the points accordingly: less than 40, 40 to 60, more than 60. Preceding diarrhea, if it is present, 1 point, absent 0 point, and MRC sum score again is the power charting from all 4 limbs. And this is done twice, one at the admission and one at 1 week after the admission. And both of them tell us about the probability that the patient will walk independently, at how much percentage are the chances that he'll walk after 1 month, 3 months, and 6 months. Okay, we come to pathology. Pathology is quite simple. It is basically endoneural inflammation from complement and macrophage lineage cells. And the pathological hallmark, which I can say, is basically macrophage in contact based induced injury. If it is injuring Schwann cell, it will cause AIDP. If it injures axons, it will cause Aman and M1 variants. Pathogenesis, though the precise mechanism so far is not completely understood, autoimmune disorders have been considered, it is considered to be an autoimmune disorder with obvious T cells, B cell reacting to self antigen. May be triggered by environmental agents in susceptible hosts. It has been predominantly pathophysiologically that it is post-infectious molecular mimicry has been suspected, especially in myelofascial variant and axonal variants. Infections of GI and upper respiratory infections are common. Triggers for GBS like Campylobacter jejuni infection is the most common form. Then upper respiratory infection by cytomegalovirus, Epstein-Barr virus, mycoplasma pneumonia, Haemophilus influenza are also triggering events. Recent infection with Zika has also shown that post-Zika virus infection has caused GBS, and mostly unvariant has been seen. Then what are the non-infectious risk triggering events for GBS include trauma, vaccination, immunosuppression, and pregnancy. Okay, next question is, can COVID-19 infection cause GBS? And the answer is yes, GBS has been reported in association with COVID-19 infection, including all the types, demyelinating, axonal, Miller-Fisher variants from all over the world. And below is the reference for the same. Here, one reference is from our side. A multi-centric study has been done in Maharashtra from multiple hospitals, and it has clearly shown that GBS has been associated with COVID-19 infections. Times of India 2 days back has published the same papers regarding the Maharashtra study and showing the clear-cut evidence of GBS along with COVID-19 infection. Okay, next question is, can COVID-19 vaccine cause GBS? Answer is no. So far, no link has been attached between COVID-19 vaccination and GBS. Okay, next, if the patient develops first attack of GBS within 6 to 8 weeks of any vaccination, not just COVID vaccination, any vaccination, that person is particularly at high risk and should not receive the same vaccine again. That's an important point to be noted. Okay, we come to differential diagnosis. We have differential diagnosis like acute transverse myelitis or myelopathies. Then we have neuromuscular junction disorders like myasthenia, botulinum toxins. Then infections by affecting anti-horn cells like poliovirus, West Nile, enterovirus, rabies paralytic forms, periodic paralysis, toxins like thallium, arsenic, lead, hexacarbons, organophosphates. Next is carcinomatous meningitis, which is painful paralysis, basically. And paralysis are the important differentials for GBS. Treatment. Coming to treatment, main and important treatment is multidisciplinary medical supportive care, which will basically prevent your mortality in GBS patients. Next is immunotherapy, which is first line treatment, important treatment, IVIG and plasma exchange. Now, many RCTs have shown that Plasflex is efficacious up to 4 weeks after the onset of symptoms, and IVIG up to 2 weeks after the onset of symptoms to hasten the recovery. Early treatment is preferable because it limits the endoneural inflammation and obviously nerve injury. Okay, how do you do it? Plasma exchange, basically 200 to 250 ml per kg in 4 to 5 sessions over 7 to 14 days. And IVIG is given as 2 gram per kg given over 4 to 5 days. Now, next line is very important. Many RCTs have indicated that 40 to 50% of the patients did not improve significantly either after IVIG or plasma exchange. As defined, they have defined the improvement as improvement of 1 or more points on GBS disability scale at 4 weeks after the treatment. Okay, next question is, which is superior, Plex or IVIG? The answer is both are equivalent in efficacy. Still, we prefer IVIG as first option due to its ease of administration and widespread availability. Okay. Is Plex followed by IVIG or IVIG followed by Plex help? The answer is no. Combination of Plex and IVIG studies have not found any superiority to any of the monotherapy. And below is the reference for the same. Next question is there any role of repeat IVIG? The answer is no. Second dose, or you can say high dose IVIG. There has been a study, international second dose IVIG ICIT study, which has recently published observation that it did not show any better outcome after second IVIG in GBS with poor prognosis. And below is the reference for the same. Next question is, what do you do when the GBS doesn't improve? Basically, you stick to single treatment modality, do early tracheostomy, do early PEG if warranted, if required, and early discharge to a rehabilitation for a long-term acute rehabilitation care facility. Okay, certain special group of patients, both plasma exchange and IVIG can be used in pregnant women. However, IVIG is less likely to cause hemodynamic instability in pregnant ladies. Although the incidence of GBS is slightly lower in children, but the treatment recommendations are similar, and it has been found that plasma exchange is slightly superior in shortening the ventilatory support in children patients. Okay, patient support and education is important. What are the recent advances? So now they have targeted complement and neonatal FC receptor inhibitors. They have formed the hypersilated IVIG for future treatment. Drug like eculizumab anti-C5 complement inhibitor has been used as an add-on therapy with IVIG, has shown a better result so far in phase 2 trials and has been taken up for phase 3 trials. So in future, we might see eculizumab to be as an add-on therapy with IVIG with better outcomes. Another drug is humanized antibody against C1q component of the complement is being studied. It is still in phase 1b trial, but has shown a promising results. Next is preclinical studies indicated that silated Ig fractions have almost 10-fold more efficacy than IVIG in animal models so far. So they have taken this for a human study, and probably in next few years we will have a better results from silated IVIG fraction. And this finishes my slides. Thank you so much for hearing.
Okay. Shiraz has done a very, very composite job, and he has stuck to the main text of the Continuum article. A few comments. One is she has highlighted COVID and GBS, and that was very appropriate. And remember one thing, in your practice now, whether you get a new onset headache, whether you get a peripheral neuropathy, whether you get GBS, whether you get a facial palsy, you get a Bell's palsy, or you get herpetic vesicle, whether you get history of COVID or not, please test for COVID, RT-PCR, and for that matter, if you don't get a history of fever, if it's negative, try and do a spike protein. Very often these things you'll be surprised to find they're associated with COVID. The next point I want to say that he has put 2 slides and two benign slides and said differential diagnosis. But very often at 11:30 at night, if you go down to the CMO's office with the history that this patient has developed lower limb weakness in the morning, how do you manage it? It can be very, very difficult at times. So keep your antennae very open with the list of differential diagnosis. There's a slide that says that patients don't do well. In fact, they do well. If they're off the ventilator, even if they're severely paralyzed, you'll find that between 3 months, 6 months, and 9 months, they get fully mobile. I've had a person who has been on a ventilator for 3 months, and then he was bedridden for another 3 months, and within 3 years, he was in Dubai working as a computer operator. So that was a pleasant surprise for me. And IVIG and Flex, it doesn't matter what you do. You do what is practical to you, what you can do in your setting. So overall, Shiraz, it's a very good job. And anyone else wants to make any comment, they're most welcome to come in.
Thank you, sir.
Yeah. Anyone else want to say anything? Yeah, so can we log out now? We have finished the last talk, Shiraz being the last batsman. In fact, he was the third batsman.
Thank you so much, sir.
He had to bat last for so many reasons.
Extremely sorry for that.
Not to worry. It happens to all of us. It happens to the best of us. So I think we'll leave and we'll log off. Thank you very much for joining in. And it's a very, very good topic that you managed very well. God bless you. Thank you very much. Have a good day.
Thank you, everyone.
Bye-bye.
Thank you.
Bye.
Please log in and fill up the form, Google Forms. Yeah. Bye-bye.
Bye-bye.